It's 5 and we'll begin our session now. A very warm welcome from Shaw family as well as Eklg core group to this live webinar on a series which we are beginning today on endothelial keratoplasty. A special warm welcome to all the people who have joined us and shown us their trust across the borders. That is from Bangladesh, Nepal, Malaysia, Indonesia, especially Mexico, Cairo, and many other countries. We are really happy to have you with us. On this first series, we begin with the first session with remarks of endothelial keratoplasty. And I would just like to share one picture which I think says it all about this session. So this was a patient Can everybody see my screen? This was a patient that had walked in last week to my OPD, and the vision of this patient was 636. Patient complained of decrease of vision and lot of scattering of light after 1 year of the cataract surgery. And what was very interesting was the ASOST picture of this patient, which showed the PACI of 509 microns, in spite of having the TM tear and a large area in the center where the DM was lost. So here are the questions, I think, and we have an amazing panelist and the faculty with us. On the panelist list, we have Dr. Umang Mathur, Dr. Tatial, and we have Dr. Rajesh Fogla, Dr. Bhaskar Srinivasan. And we would have a session with all these questions being answered, which would be pertaining to the question we just raised with this patient, very commonly seen in our OPD. We would have Dr. Dipinder talking about why are the cells important, Dr. Praveen connecting it to the role of the DESCEMET membrane with the underlying stroma, and then Dr. James taking us to the path of why does the cornea remain clear, and what happens when it doesn't remain clear, and how does the corneal edema progress. Onto that, we will go on to talk about the certain about diseases which we commonly see by Dr. Rahul, Dr. Vikas, and Dr. Praveen taking us through the fuchs and early and late pseudophecubulous keratopathy. And finally, Dr. Rajesh would show us the way as to when do we decide to do a surgical intervention and treat these patients to replace the endothelium. With that, we would have Dr. Tatial enlightening us with how did the endothelial keratoplasty begin and how it has evolved over a period of time. From very important two talks we have then upon the recent developments of the DSAEK and the medical and the cell regeneration therapy we have to our baggage now to treat these patients with Dr. Roberto and Dr. Tiziano joining us. So let's begin with the session with Dr. Dipinder, and welcome Dr. Dipinder. We would begin your talk with why are these endothelial cells valuable? Over to you.
Thank you, Dr. Nidhi. Am I audible?
Yes, you're very much audible.
Okay, I'll just share my screen. So is the slide visible? Hello?
It's yet not visible. I think we'll give it a second. You'll have to share your screen.
It's not. Okay, you can't see the screen?
We cannot see your screen.
Just give me a minute.
Yes. Yes, we are there. You'll have to make it full view.
So is it visible now?
Yes. Thank you.
Okay, so I will begin. Good evening, everyone. And at the onset, I would like to congratulate Dr. Nidhi for this great initiative and also thank her for making me a part of this journey. So I will kick off this session with the first presentation, and it's about the endothelial cells and their importance. So endothelial cells are important because they maintain the water balance in the corneal stroma, which is important for the optical clarity. I will briefly touch upon a few topics like the embryology or the origin of these endothelial cells, their basic characteristics, how do they respond to stress or trauma, and very briefly about the regeneration potential of these endothelial cells. Now, this is the 6th week of intrauterine life, and here you see the neural
Dr. Dipinder, you are mute. By mistake, you are mute.
Am I audible now?
Yeah, yes, you'll have to go back to the last part.
Okay, so this is the first slide for the embryology or the development of endothelium. And this is the 6th week of intrauterine life where the neural ectoderm has formed the optic cup. And Overlying surface ectoderm is now forming the lens vesicle, and with time the lens vesicle will be completely formed and it pinches off from the surface ectoderm and forms a future lens. The surface ectoderm will give rise to the corneal epithelium and the conjunctiva, while the neural ectoderm will give rise to the RPE and retinal pigment epithelium. The rest of the structures are made by the neural crest. Now, before we go to the neural crest and how it forms the anterior segment, the neural crest is basically the junction between the neural plate, or in case of eye, the optic cup, and the non-neural ectoderm, or in case of eye, the surface ectoderm. Now, these cells have, these cells also called as the neural mesenchymal cells. They will form the rest of the anterior segment structures in three waves. The first wave gives rise to the corneal endothelium. The second wave gives rise to the corneal stroma, and the third wave will form the iris stroma, trabeculum, sclera, and choroid. A clinical corollary to it would be in Peters syndrome, and it is believed that during the intrauterine development, the incomplete migration of these mesenchymal cells or an incomplete separation of the structures formed by these mesenchymal cells leads to development of this anomalous eye. And here we see a corneal opacity, which is predominantly posterior in posterior stromal, along with the iridocorneal adhesions, and at times an associated cataractous lens which is adhered to them. Coming to the corneal endothelial cells morphology, these cells have an approximate size of around 200 microns. Most of the cells are hexagonal in their appearance, and it's normal to find cells which have 5 to 7 sides. They're relatively flattened cells, and they have a relative nucleus bulge. Now, the topographic difference is that the peripheral cells tend to be smaller, they're compact, and they have a higher density. And the clinical relevance comes when we select a large size diameter of a DMEC graft. It will have a lot more cells, not only in number, but also peripheral cells, which have a higher potential to regenerate. Now we know that the cell density is maximum at birth, and in the initial 2 years, there is a slight drop in the cell density as the corneal diameters enlarge. Subsequently, the cell density remains more or less stable with the average cell loss of 0.3 to 0.6% per year. And in old age, there is further drop in the cell density. As you can see that in spite of loss of the cell density, the hexagonality of the endothelium is relatively maintained. The corneal endothelial cells, when seen on ultrastructure, they show high metabolic activity as observed with plenty of mitochondria and other intracellular organelles. The presence of tight junctions at the apices and the lateral margins, they have gap junctions, and therefore the barrier formed by the endothelium is partially leaky. But it's important to see that in spite of the cell counts going down to as low as 400 or below, the barrier function remains intact, and it's only the metabolic pump of the endothelium which weakens and which leads to corneal edema. Coming to the next slide, we'll talk about the DESCEMET membrane. So DESCEMET membrane is the basement membrane of endothelium. The formation of DESCEMET membrane begins intrauterine also only, and the fetal layer or the fetal part of the DESCEMET membrane has an anterior banded zone. The fetal or the anterior banded zone DESCEMET membrane is much more compact, much better organized, and more sticky to the endothelium, to the stroma, while the posterior non-banded zone, which is layered by layer deposited during the adult life, is more amorphous, and it also thickens with the as a response to injury, and therefore it is also seen to have a thickened DESCEMET membrane in patients with persistent inflammation, in patients with endothelial disease like Fuchs dystrophy. A clinical correlation can be seen when we are trying to peel off the DESCEMET membrane in young people. They form a title scroll, and also it's difficult to peel them off because the anterior banded zone is more strongly adhered to the stroma. Coming to the last segment is the endothelial replacement or the healing response of endothelium. Endothelium remarkably has very little mitotic potential, and therefore whenever there is injury to the endothelium, the usual response from the surrounding cells is by the form of enlargement of cells and migration of these cells which are surrounding that area of injury. Initially, it leads to reduced cell density in that particular zone, and subsequently, as the cells are trying to uh, cover up the area of defect, the cells are more irregular in shape and size. But over time, the cell, uh, the cell size and shape tends to get back to normal. However, the cell density remains low. We can also observe intracellularly that when there is such a healing response, you can see intracellular development of vacuoles, pigment, and the layering down of the past material in Gettate. An important healing response shown by these endothelial cells is sometimes transformation into a mesenchymal kind of cell. These cells are responsible for laying down the retrocorneal membrane or the fibrous membranes, seen typically in severe chemical injuries or severe episodes of toxic anterior shock syndrome. Now, what causes these cells, what inhibits these cells from division? There are many theories, and one of the important reasons that these cells don't divide is contact inhibition. Also, it has been said that the lack of effective growth stimulation because of the low levels of positive growth factors in the aqueous also contribute. Finally, with age, the regeneration potential of these cells goes down, and also a role of oxidative DNA damage as the endothelium is exposed to the ultraviolet light throughout the life is also one of the reasons that the cells remain arrested at this stage. Although in the last presentation we'll discuss perhaps in more detail, I'll just have a look at the cell cycle, and we see that the endothelium is stuck in G1 phase of the cell cycle because the next stage where it has to go to the S phase is blocked. To understand in greater detail, we have to see that the cell-to-cell contact or the oxidative DNA damage or with age, there's a higher level of cyclin-dependent kinase inhibitor proteins, and they prevent the switch of endothelial cells from G1 phase to S phase. I'll not go into further details as we have one presentation dedicated to it. To summarize, the endothelial regeneration strategies can be to inhibit the CKIs or to bypass the whole process by using adenoviral vectors to transfect these cells with certain viral oncoproteins and to kickstart the mitosis. ROCK inhibitors have been described to have a very effective role in that. Also, people have searched for stem cell-like properties of certain endothelial cells. These cells are said to be located in the peripheral endothelium, just near the trabecular meshwork, and they may be the holy grail for endothelial regeneration. But more importantly, whatever method we use to regenerate these endothelium or endothelial cells, it should be non-mutagenic so that it has a long-term safety. And also, these cells should divide transiently and then should stop dividing so that there is no over-replication, and therefore multilayering of the endothelium or blockage of trabecular meshwork can be avoided. So with that, I will wrap up this presentation. Thank you.
Thank you, Dr. Dipender. That actually took us back to our anatomy days where we actually went through reading all these layers of the cornea and then the detailed role of the corneal endothelium. With this, are we looking at a kind of a stationary phase or a waiting phase before we actually jump in to treat our patients? See what is the kind of cell healing which happens of the endothelium post cataract surgery.
So, Dr. Nidhi, I do agree with there should be a period where we should observe these patients, as you very well showed in the clinical case that you had just described briefly. We have to give the endothelium little chance to regenerate or perhaps readjust and develop a wound response. And many times you can see that smaller defects can be easily compensated by the surrounding epithelium, the endothelium. Sorry.
Anything from the panelists as to would you guide us to a little bit of waiting period that we should have before we jump in to treat these patients, especially the early edemas that we see post cataract surgery or in fuchs? Dr. Tatyal? Dr. Umang, any comments?
Yeah, I think one should wait at least, I would say, maybe up to 3 months before any surgery should be planned, because there are results in the cornea, especially as the Bulla mentioned, sometimes they're more compact and maybe higher results in the periphery, and the central edema takes longer to clear. So I think one should give, and all of us have seen those cases where if you wait, you're surprised that the patient recovers. So I would generally like to wait up to 3 months, unless I know I've eaten away the DESCEMETs or something like that. But otherwise, I'd like to wait.
Yeah. I think with that comment, we'll go ahead with the next talk by Dr. Praveen. And he's going to be talking about the DESCEMET membrane and the relationship with the stroma. Over to you, Dr. Praveen.
Yeah, thanks, Nidhi, and thanks, Dipender, for setting the tone of what this webinar is all about. We're sort of going back to basics to understand some of the things that we read about a long time ago and try and apply what we have read to our current scenario. So what I'll try and do in the next 10 minutes or so is actually speak a bit about the corneal stroma and the Descemet membrane. Obviously, I'm not going to be able to cover all of this in 10 minutes. But what I will do is I will avoid speaking about the normal anatomy, because all of you probably are already aware of that, but focus more on the structure of the stroma and how it actually affects surgical outcomes, with more focus on the posterior stroma and the pre-Descemet layer, which is the area of our focus now, and about the Descemet membrane as well from the perspective of surgery. Now remember that all of these are from the perspective of pre-op considerations, intra-op as well as post-op considerations, and would apply to all kinds of endothelial keratoplasty and are not just limited to DMEK, but would apply to other surgeries like DSAEK as well. So the corneal stroma, very basically, all of you know, has three major components. There's several other components, but we won't talk about that in detail. The structure of the stroma is derived from the collagen fibrils. The cells in the stroma are predominantly from the keratocytes, and the extracellular matrix is predominantly the proteoglycans, or the glycosaminoglycans that we'll look at a little more in detail later on. Well, all these structures are organized in a sort of a meshwork. They're not separate, and they're all interwoven in a meshwork, which is probably impossible for us to replicate as an artificial structure. And interestingly, if you look at the stroma from the point of view of the different layers or the levels from which the stroma is sourced, and this is mainly to compare how the anterior stroma is different from the posterior stroma. In this very interesting electron microscopic study, where the corneal lamellae that are distributed within the stroma were studied to look at their organization in different parts. Now remember that 70% of the dry mass of the cornea is collagen. And so these lamellae, or these fibrils that you see here, are basically made up of collagen. So the structure of arrangement of these lamellae are basically bands of fibrils that are bound together, is different in different parts of the corneal stroma. And if we look at the anterior part of the corneal stroma, the lamellae of the cornea tend to interdigitate quite a bit. That is, they tend to actually cross each other's path from forward to posteriorly, and some of them even angulate to the extent of 90 degrees, that is, they pass almost vertically forward. The mid-stroma, this tends to come down a little bit, and the stromal lamellae are more parallel to each other, and they become most parallel with the angulation between the stromal lamellae, the least in the posterior stroma. Now, what are the implications of all of this? We'll come to that in a minute. But also what is interesting is I would encourage all of you, and we'll send you these resources, to read the article about an architecture of corneal stroma, a lovely editorial by Anthony Braun. This is from 2001, but very relevant right now as well. And again, this article present in the same, published in the same issue of the British Journal of Ophthalmology, which speaks about the specific architecture of the different parts of the stroma, clearly shows that as you swell corneas artificially, the anterior stroma remains relatively unchanged. And it is the posterior stroma that actually tends to swell the most from the point of view of artificial development of corneal edema. Now, this is again very interesting because if you look at the development of corneal edema, you'll actually see that corneal edema tends to develop most often in the posterior stroma first, if you observe it carefully, and then moves on to the anterior stroma. And also in this article, they realize that if you look at the anterior stroma, which is the white circles right here, even with significant duration of hydration, there was no significant thickness in the anterior stroma, whereas the posterior stroma continued to swell. So when you're looking at a patient who has corneal edema, the anterior 120 microns of the corneal stroma probably does not swell. And it's the rest of the corneal stroma that is contributing to the increase in the thickness of the cornea as you're evaluating that patient. The other important aspect of the arrangement of collagen fibrils within these lamellae is the optical properties. Again, we're not going to go back to school to talk about the spacing and why it is important for this spacing to be regular. But what is also important is the fact that if you do X-ray diffraction studies, again, this is from Kenneth Meek and his group, fantastic studies about X-ray diffraction, which tell us a little bit about the organization of corneal fibrils and lamellae within the cornea. You see that they're actually interwoven and they're actually interdigitating around the limbus, and they interdigitate less as you come to the center of the cornea. Potentially why you probably see weaknesses of the cornea like keratoconus occur in the center, but not towards the periphery. But what is also interesting, if you look at the transmission characteristics of the cornea at different depths from anterior to the posterior stroma, you will actually see that the anterior stroma tends to have more reflectance as compared to the posterior stroma. And this is again is confirmed by this lovely article from Edelhauser, where they looked at the differential scattering properties of the anterior and the posterior stroma. And they found that the anterior stroma actually tends to scatter more light as compared to the posterior stroma. And also the transmissibility of light of the posterior stroma is much better than the anterior stroma. What this article really says is if you divide the stroma into anterior and posterior, optically the posterior stroma actually is clearer than the anterior stroma. And from the previous article, we learned that the anterior stroma is what really provides strength to the cornea, whereas the posterior stroma probably does not provide as much strength, but actually adds clarity to the entire optical properties of the cornea. And interestingly, and we will have this discussion later on, is about when to intervene when you have a patient with corneal edema. It is reminiscent of what we read in our ophthalmology, that a change in the distance between the corneal fibrils because of swelling, as you see in the picture below, will actually retard the light transmissibility through the cornea. And this is interesting because hydration of corneal edema not only changes the transmission characteristics of light, but it also does this differently for different wavelengths of light. In fact, it affects blue light much more than red light, and it also causes a lot of scatter, which is something that we really do not measure in the clinic. And so if a patient is complaining of visual phenomena that we measure visual acuity, it might not be the best measure of making a decision about surgery. The other interesting aspect is as the cornea gets more and more hydrated, the refractive index of the cornea also reduces. So it's not just a change in the transmissibility of light, but also a change in the optical properties from the point of view of how light is refracted when it goes inside the eye. So there probably is a change in the refractive error as well. So what are the implications of what we just spoke about? Number one is the fact that the separation of corneal lamellae in the posterior cornea is different from in the anterior cornea. And because of that, you probably will be able to dissect the posterior corneal lamellae, which is something that we all know much more easily. And this is the origin of lamellar corneal surgery. And this is the reason why dissection in the posterior stroma, like in DSAEK surgery, is much more easy than dissection in the anterior stroma, like doing for an ALK. Also, when you're looking at corneal edema, you see that because of the separation of the lamellae, the corneal edema tends to aggregate within the lamellae or between the lamellae. And so there is separation of lamellae and there's an increased anterior-posterior thickness, but there is no increase in the diameter or there's no stretching of the cornea laterally because that is not how the lamellae are arranged. And also edema, like we spoke about a little earlier, is more evident posteriorly than anteriorly earlier in the course of the disease. Additionally, whenever you have corneal edema, because most of the thickening occurs in the posterior stroma, there is a minimal change in the curvature of the anterior stroma. Otherwise, you would have a lot of bumps on the cornea if you have had corneal edema with the same structure in the anterior and the posterior stroma. Also, early edema tends to cause light scattering and also changes the optical properties of vision, which probably might be evident more for the patient than for us because we do not measure these in our routine clinical practice. Now let's move on to the kind of collagen that is present in the cornea. Collagen is part of every structure or tissue in the human body, and a lot of our tissues actually do have collagen. And there are different kinds of collagen in different types of tissues. Mainly the type 1 collagen, which forms the bulk of the cornea, actually is present in a number of other tissues in the body. Whereas type 4 collagen is typically the collagen that is deposited in the basement membrane in various tissues in the body as well. And this is a similar kind of collagen that you will find in the descemet membrane too. What is interesting is if you go back and read about the different kinds of collagen in the body, the kinds of collagen also tends to organize themselves in different ways. So you have the type 1, 2, 3, 5, and 9 collagen, which tend to form lamellae or structures that tend to interdigitate, very similar to connective tissue elsewhere in the body, like ligaments and tendons and other parts of the body, and also very similar to the corneal stroma. Whereas type 4 collagen generally tends to form sheets because this forms a basement membrane on which cells tend to grow. And so the kind of collagen is also determined by the requirement and the kind of function that they have. Now, the corneal stroma, as we discussed so far, the anterior as well as the posterior stroma arrangement is also important from the point of view of creating DSAEK tissues. Earlier, surgeons tried to use the femtosecond laser to actually dissect the posterior cornea to create DSAEK lenticules. But what they found was as they tried to do this, the cornea tended to become very irregular in the posterior stroma just because of the arrangement of the stromal lamellae, and also because of the fact that the posterior stroma tends to accumulate more fluid. So the femtosecond energy seems to be getting dissipated in the posterior stroma as compared to the anterior stroma. And compared to a microkeratome, as you see here in the bottom right, the bed or the stromal bed was not as clear and smooth as when dissected with a microkeratome. This was corroborated clinically as well when various studies, at least 3 publications are available, where lenticules that are created using the femtosecond laser tend to induce more stromal scarring as compared to those lenticules that are created using the microkeratome. And the microkeratome lenticules also tended to result in better visual acuity as compared to those created using the femtosecond laser. The other component of the corneal stroma that we spoke about is the keratocytes. So these are not the only cells in the cornea, but these are the cells that are in the closest proximity to all the action that is happening in the cornea. In the anterior stroma, the keratocytes again are much denser. These are the nuclei that you see on confocal microscopy. The posterior stroma, they're not as dense. And so the total volume or quantity of keratocytes in the posterior stroma is less than in the anterior stroma. They also tend to get activated less commonly than in the anterior stroma. And this is probably the reason why when you do DSAEK surgery and you actually attach or appose stroma to stroma, the interface does not scar as much as you would get when you have an interface in the anterior stroma. And this is again correlated to the fact that you don't have fibroblastic transformation of keratocytes as commonly in the posterior stroma, one because of volume, and also secondly because of the fact that they don't tend to get activated as much. And that's probably the reason why whatever interface haze you get in DSAEK surgery is very limited, and it tends to come down quite significantly with time as well. The other interesting part of the cornea is the extracellular matrix and the glycosaminoglycans. Now, you also would know that the chief glycosaminoglycan in the cornea actually is keratin sulfate and is present majorly in the corneal stroma, whereas the other glycosaminoglycans are distributed in the extracellular matrix of the posterior part of the cornea, as well as other cellular components of the cornea, like in the keratocytes and also in the endothelium. Now, what is interesting to see the fact that if you store corneas in various preservation media, especially organ culture and in media that contain dextran, the percentage of these glycosaminoglycans actually tends to go down in these media. And so it also alters the glycosaminoglycan concentration. And so the swelling characteristics also tend to change. So your plans will also have to change depending on the duration that you store a tissue in these media. Now, in addition to these glycosaminoglycans, there are several extracellular matrix components within the corneal stroma, and several of these are also inflammatory components, and you also see that there are several publications that talk about alterations in the extracellular matrix and also activation of various inflammatory mediators within the extracellular matrix in patients who have bullous keratopathy. So in effect, bullous keratopathy is not just alteration of the corneal swelling and accumulation of fluid, but also seems to be a micro-inflammatory response to whatever changes are happening because of the inflammation and also because of the accumulation of fluid. Now, coming to the posterior corneal stroma, this is a famous article from Professor Dua that spoke about the presence of Dua's layer and the Descemet's membrane as two distinct layers. And you can see from his EM studies that the Descemet's membrane and the Dua's layer have been shown as two distinct layers that can be distinguished or are held together with fibrils, as you can see in figure D. But these are attached very firmly at about 8 or 8.5 millimeter diameter of the cornea and do not extend right up to the periphery. Another article about a couple of years after Dua published his the evidence of the Dua's layer, again from a number of ophthalmologists, again tended to disprove the fact that a pre-Descemet's layer or a Dua's layer does exist. And they actually base this on the variable thickness of this pre-Descemet's layer in different parts of the cornea. But then again, this actually proves that there might be a pre-Descemet's layer, except that it is variable in different parts of the cornea. And this is evidence from several surgeries. This is an example from a patient to whom we're doing DALK. And if you can actually see the OCT of this patient with the bubble between the Dua's layer in front and the Descemet's behind, you actually can see a clear demarcation or a clear separation between these two kind of layers. And you will also see that as the bubble is excised, incised, or the Dua's layer is incised, as you can see here that I'm doing, the bubble escapes and you can see that Descemet's membrane bounces back. Again, evidence about two anatomically as well as functionally separate layers within the corneal stroma. Why is this important? Because if you correlate this to DMEC versus PDEC, PDEC is supposed to be an alternative surgery to DMEC, where you transplant not just the Descemet's membrane, but also the Dua's layer. The fact that because the Dua's layer is adherent to the cornea at about 8 to 8.5 millimeter zone diameter, limits the size of your PDEC graft that you can put inside the eye. And though PDEC does result in good visual outcomes, you are limited by the potential number of endothelial cells that you can transplant inside the eye. So Dipender also spoke about the ultrastructure of the Descemet's membrane, the anterior banded and the posterior non-banded zones. What is important to also remember is that the posterior non-banded zone tends to be variable in thickness. So this thickness continues to increase throughout life. And in an older patient, you will have typically a thicker Descemet's membrane, which also is easier to strip during surgery as compared to a younger patient where the adhesions are greater, like Dipender mentioned, and is also more difficult to strip because the thickness is quite low, can be as low as 4 microns in thickness. Also, the Descemet's membrane removal by itself seemed to have its own side effects. And again, a fantastic review article by Steve Wilson, who speaks about the effect of removing the Descemet's membrane on the residual corneal stroma. And he hypothesizes that once you remove the Descemet's membrane, it sets into effect an arcade of events which leads to the deposition of several inflammatory mediators and also activates fibroblasts from the limbus as well from the aqueous. And because of this, you tend to have more scarring or more deposition of extracellular matrix in the posterior part of the cornea that is denuded of Descemet's membrane. And for this reason, he says that it's very important to preserve as much Descemet's membrane as possible because regeneration of Descemet's membrane is not easy and does take quite some time. Lastly, let's just talk about the effect of the Descemet's membrane and the effect of various stains in the Descemet's membrane. Different people have used different kinds of stains from brilliant blue to ICG to trypan blue, but trypan blue seems to consistently stain the Descemet's membrane very effectively. But what does the stain do? If you have unstained Descemet's membrane, the elasticity is usually better. But if you stain the Descemet's membrane with trypan blue, the Descemet's become more rigid and it also becomes less elastic. So it tends to tear more easily and it also tends to form a scroll less easily. So if you want a Descemet's membrane to behave in a manner that it doesn't scroll too much, then staining with a little extra with trypan blue generally will help during surgery. So to sort of summarize this back and forth anatomical clinical correlation, just the fact that a few take home points, the structure of the organization of the collagen in the stroma will determine where you get your corneal edema. And that's the reason why corneal edema tends to be maximum in the posterior stroma as compared to the anterior stroma. Disorganization of the structure of the lamellae can lead to early visual effects because of scattering of light, not just because of retardation of transmission of light in the eye. The glycosaminoglycan distribution also affects fluid distribution in the stroma, and this is why you have more fluid in the posterior stroma and also tends to remain in the posterior stroma longer. When you're trying to do dissection of the posterior stroma, this is easier because of the organization of the lamellae, and so it allows you to do dissection more easily. DMEK allows you to do larger grafts and put in more endothelial cells than PDEC because of the anatomical challenges that occur with the pre-Descemet layer. And with age, the Descemet membrane thickens and also becomes stiffer. And especially if you stain it with trypan blue, it tends to become less malleable and more rigid with time. Thank you very much.
Thank you, Dr. Praveen. That was a beautiful connection of the anatomical layers and the practicality of it in all the EK surgeries, the DMEK and the DSEK. I think the question on the group, which is coming on the WhatsApp as well on the Facebook, is that can we extrapolate this information to also the doing the DMEK stripping in the DM stripping in patients of failed graft? And the second question would be also the deciding upon whether it is actually related somewhere to what you have told, that we have more of DMEK graft detaching than DM detachments in patients where we do DSEK grafts.
So I think the first point is related to the fact that you need to strip Descemet and have bare stroma if you want to oppose Descemet to the stroma. There have been publications about non-stripping DMEK as well, and seems to be relatively successful. But then from the fact that if you have a disorganized Descemet membrane and a Descemet membrane that is thickened because of abnormal endothelium, it tends to become quite thick with time, tends to develop a thicker posterior collagenous layer. And this tends to reduce the attachment properties of the new DM that you put in place. Additionally, a Descemet membrane from a patient who has PBK, remember PBK, not Fuchs, again, does not support the movement of endothelial cells because of a change in the extracellular matrix over the Descemet membrane. And that is the reason why it seems that at least anatomically, it's important to strip the Descemet membrane in cases of DMEK surgery at least. Now, from the point of view of detachment of grafts in DSEK versus DMEK, DSEK grafts tend to attach much better because they have the same normal shape as your host cornea. They don't tend to curl up or scroll up because they're relatively thick and maintained, and they also have surface tension that acts quite significantly to keep them attached. Also, initially, it seems that presence of fibronectin and several other factors keeps these grafts attached. Whereas for DMEK, the natural tendency of the Descemet membrane because of the elastin tends to cause it to form a scroll, and that's why it tends to detach much earlier than DSEK. And this is the reason why air bubble management becomes much more important in DMEK surgery as compared to DSEK surgery.
I'll just bring in the panelist here for the question on the chat box by Dr. Bharati, that are we able to see clinically or distinguish between the Duas layer and the Descemet membrane?
Yes, certainly. From the point of view of doing DALK surgery, you can easily recognize the two bits by looking at the residual fibrils and the crisscross nature of the Duas layer, whereas Descemet is pristine, is really clear, and tends to dry out quite quickly, so you can make out the difference quite easily. From the point of view of doing endothelial keratoplasty and stripping tissue, you can't strip the Duas layer as easily as you can strip Descemet membrane. You'll need an air bubble to do that. And from the point of view of stripping Descemet membrane in a patient, you can strip Descemet membrane easily without causing stromal incursions. But if you try to strip Duas layer again, you will cause fibrils that are loose and you will induce scarring. So it's very important not to strip Duas layer. And you will also see indentation on the anterior stroma as you strip. So you can make out the difference.
Dr. Tatyal, just would like to bring one comment from your end. You have an ASOST mounted slit lamp, the microscope at your OR. Does that make a difference here?
No, it really does not make a difference if you see through the routine microscope, or if you have an attachment of IOCT in the microscope during surgery. What Praveen was talking about, correct. Clinically, yes, you can judge if you are doing DALK, you can see the surface wise, you know that what type of bubble have been created, and it very easily can be detected if you have been over the DeVos layer in a dark surgery. But as far as doing a DESCEMET stripping, it's very difficult to judge what stripping you are doing. Are you really damaging the DeVos layer? It's very difficult to judge that. And Parveen rightly said, it's difficult to strip also. It's just a DESCEMET complex which comes out. And IOCT doesn't make any, significant, microscopic pictures to be seen. It's just, physical structure which can be seen during the surgery.
Thank you, Dr. Tatyal. And with that, we'll go ahead to the next talk. That will be by Dr. James. And he would be talking about the cornea clarity. How does it maintain its clarity? Over to you, Dr. James.
Okay, can you hear me?
Yes.
Okay, sounds good. So, good morning, everybody. I'm going to be talking about what happened. Oh, sorry, not corneal edema. Let me change the. Let me change my. One second. Wrong presentation. Oh, sorry. Sorry. Wrong presentation. Let me share the right one. I apologize.
That's okay. That's your second presentation. You'll hear how.
Yeah. There we go. And we're going to, okay, so sorry about that. So good morning. It's early here. Sorry for that error. I'm going to be talking about how the cornea remains clear. I'm coming to you from San Antonio, Texas. I don't have any disclosures for this talk. And as Praveen mentioned, the corneal clarity and transparency mainly has to do with the arrangement of the collagen fibrils in a regular lattice pattern, like you can see in the picture here. That decreases the light scatter and gives us a clear cornea. Obviously, there's a lot of math that goes into that I'm not going to get into or nor understand. But it's, if you think about it, the sclera is opaque and the cornea is clear, and it has to do with the arrangement of these collagen fibrils. This was proposed by Dr. Morris, and so when I was doing a little research on this, just to take a step back, I didn't realize all the things that Dr. Morris invented. So he is English, but lived in the US because his wife was American. He discovered specular microscopy, impression cytology of the conjunctiva, fluorescein staining, and the pump leak theory of endothelium. So we owe a lot to Dr. Morris. And I read a little bit about him, and this was one of his quotes. It said, why he loved ophthalmology and research was the ultimate reward is to have had my mind engaged in creativity challenged almost on a daily basis. This is a privilege restricted to few occupations, and that he must be grateful. So I think we can reflect on that, especially during COVID, where a lot of us weren't working. You kind of miss it. And I don't do a lot of clinical research, but even in, it's bench research, but even in clinic, we're able to just appreciate better what we have the privilege to do. So what can affect corneal clarity? Well, as Praveen said, and Dupender before, anything that can cause an opacity, anything that affects that arrangement of fibrils can cause a decrease in corneal clarity. Trauma, cell toxicity, injury, burn, edema, and it can start at the ocular surface and go all the way down to the endothelium. Corneal clarity is linearly related to the hydration status. As Praveen mentioned, the cornea only swells in the anterior posterior dimension. It doesn't swell in diameter. So there's a linear relationship between corneal thickness and its hydration, and thus its clarity. And another interesting thing is the cornea remains in a state of partial dehydration. So it's about 78% hydrated the majority of the time. So it's like you're posing for a picture and all of us suck in our belly so that we look good in the picture. That's what we're trying to maintain in the cornea all the time. And so the homeostasis of the cornea is maintenance of this partially dehydrated status. And so the steady state has some important elements, starting with the barriers of the epithelium and the endothelium, the pump function of the endothelium, and the inherent swelling pressure of the lamella in the cornea. So starting with the epithelium, that has the strongest barrier function. It has tight junctions, and it's basically impermeable to liquid and to ions, okay? And then the stroma has the glycosaminoglycans that make it like a sponge. That's what wants to swell, and the rest of the cornea is fighting that. The endothelium also has a barrier function, so the aqueous doesn't go into the stroma, but its junctions are kind of leaky, and they're not quite as impermeable as the epithelium. That's why when they're damaged or when the pressure's high, fluid can flow into the cornea. And then most importantly, the endothelium has active transport of ions that creates an osmotic gradient that allows fluid to flow out of the cornea and into the aqueous. And these are sodium potassium ATPase as well as bicarb pumps. That's why certain medications that inhibit bicarb can cause the pumps to not work well. Lastly, the pumps are temperature dependent. So the warmer it is, the better they work. If the cornea is chilled, the endothelial pumping gets bad. So corneal edema occurs if the epithelium is damaged. This is easy to conceptualize. If the barrier is breached, fluid flows into the stroma that wants to swell. If the endothelium is damaged, you have breach of the barrier and you get fluid flow in. And if the pumps break down, the stroma swells. In IOP, you have damage to the endothelial cells and you have increased flow through these leaky junctions. And so focusing more on the endothelium, when the endothelium is damaged and you get corneal swelling, the various ways in which the endothelium can be damaged can happen from the irrigation solutions you use, such as low osmolarity or low calcium. If it's too acidic, if it's too basic, also things like the instrument cleansers, they can have enzymes in there that damage the endothelium. You can have low endothelial cell density because of previous surgery, endotoxin from bacterial infection, and then also Fuchs dystrophy and pseudophakic bullous. So any of those situations will cause corneal edema. So that's all I have on my brief 5-minute talk here, and I'll turn it back over to you, Nidhi, and we'll continue. Thank you very much.
Thank you, Dr. James, for that wonderful talk. I think we'll take the questions for you a little later, and we'll go on to the next talk, and that will be by Dr. Sunita, and she will be talking about how important it is to image the endothelial cells. Over to you, Dr. Sunita.
Yeah, thank you, Nidhi. Is it on share option? Because I'm not able to see the presentation.
We can't still see your presentation. I'll just check. You can share your screen now because you're a co-host with us.
Yeah, Nidhi, are you able to see the presentation?
Not as yet, but we'll wait for a second. If we have an issue, we can go to Dr. James to complete his talk.
Okay, will it be okay? Because I think I don't know, this can't figure out.
Okay, so what we can do is we'll come back to you and we can do Dr. James. Continue Dr. James.
Okay, all right.
Dr. James, stop your presentation. We can't hear you as yet. James, you need to check your mic. There is some issue with your mic. Yeah. Dr. James, can you hear me? There's some issue with your mic, Dr. James. There's some sound which is coming from your background.
I think the host has to check. There's some audio problem though.
There is an issue with Dr. James' mic, I believe, not with us, because you are very audible. We'll Dr. James, you'll have to mute yourself, please. Dr. James, you need to mute yourself. We'll go on to Dr. Sunita's presentation. By the time you can check your speaker, I think you can do that. Dr. Sunita, can we start your presentation now?
Hello, Vinny.
Yes. Yes, Dr. Sunita. Can you share your screen, please?
Yeah, is it seen, Vinny?
Not yet.
So we begin with Dr. Sunita.
Can you share your screen, ma'am, please? Yeah. Yes, now it's visible. Thank you. Can you start the slideshow? Yes, thanks. Go ahead, ma'am. Please go ahead. It's not audible. You need to unmute yourself, ma'am. We can see your screen. Can you unmute yourself?
So my topic will be mostly on imaging of the endothelial cells and its clinical relevance.
You're not audible, Dr. Sunita.
Nidhi, it says you're muted by the host. It gives this message. Is that okay?
Your
I'll
order.
just,
Go ahead.
Okay.
yeah.
Seems like it's muted by the host.
We must have done that when there was a noise in the background. Now you're unmuted and you can please begin.
Okay. Specular microscopy is based upon the optical principle of specular reflection. And so when we look at the interpretation of specular microscopy, we have to see that when we look at the image, it is of interpretation quality, which means that we have to see whether the image is analyzable or not. Because it could be that, like, let's say, now this cartoon just explains how the specular imaging works. We have the light source and it falls upon the endothelial layer, followed by the camera, which shows the specular image or the mosaic of the endothelium. Now, if there's anything in front of the endothelial layer, like let's say on the precorneal tear film or in the stroma, in the form of edema, or if there's a haze on the precorneal tear film, all these things will affect the acquisition of the imaging, as a result of which the image, the interpretation of that specular interpretation microscopy will not be very reliable. So in a way, we have to, when we see a specular image, always we have to check the images of good quality to be analyzed or not, and thereafter do a clinical and a specular correlation. This is one example of a good analyzable image of a 10-year-old. So you can see that the cells are of the cell boundaries are easily seen. So this image is analyzable, and whatever parameters are displayed are accurate parameters as per the image what we see on the specular microscope. Now, similar to what affects the imaging of the endothelial cell layer in Fuchs endothelial dystrophy, because of Gutty formation, there is an interference on the specular image which is acquired through the microscopy, as a result of which the Gutty interfere with the imaging of the endothelial cell layer and hence cause areas of dropout in specular imaging. Now, this kind of dropout area will depend upon the type of Gutty what we see in a given patient, so it will be quite variable. So when we look at specular microscopy in a Fuchs endothelial dystrophy, although it helps in determining the relative extent and nature of the DM alterations or Gutty, it is not always a proxy measure of the endothelial function, because there's no direct correlation between the Gutty what we see and the endothelial function. Now, to explain this, I'll go through some examples. Now, for a Fuchs endothelial dystrophy, our management parameters for surgical decision-making always depends upon the patient's complaints. Tachymetry, which is not just the central, but also a comparison with the mid-peripheral, and the type of subepithelial changes that we see in the subepithelial and the anterior stromal layer. Specular microscopy is helpful only if the images what you procure on specular microscopy are of analyzable grade. And let's see some examples to understand this concept a little better. Now, this was one patient who's a 32-year-old chemistry researcher who had an accidental entry of some chemicals in a lab while doing some experiments. And locally, when she went for a routine checkup following this accident, she was told like there's something wrong in her eye. She had suffered a very trivial injury, not a very major one. Vision was 20/20 in both the eyes. Before this episode, there were nil visual complaints, and the patient had 5 numerous Gutty with pigments on the endothelium, and cornea was compact. There was no subepithelial haze. The pachymetry was in the central cornea was 468 in the right, and the left eye was 470 microns. Now, this is the specular imaging of this patient of the right and left eye. So this is a case of Fuchs with numerous fine Gutty. Specular images in this picture are non-analyzable because we can't see the endothelial cells. Endothelial function, however, is still maintained because the patient does not have any visual complaints. There's no clinical edema, cornea is compact, and epithelial is normal. Now, why I have put this cross on the quantitative parameters is because this report, what we get from the microscope, is not reliable because this imaging was done in the auto mode. This is not reliable because this does not reflect as these cells are, the imaging is of non-analyzable grade. Now, we know that post-cataract surgery decompensation Fuchs endothelial dystrophy, there's a high risk if the cell count is less than 1,000 cells per millimeter square. Now, how do we apply this? And how does specular microscopy help us in determining our plan for the surgical intervention in these patients? Let's say another one patient who is 70-year-old, and she complains of blurred vision. Vision is 20/60 in the right eye, left eye is 20/80. She has cataracts, and the pachy is 572 in the right eye and 562 in the left eye. Corneas are compact with epithelium being normal. This is the imaging of this patient. The right eye shows few dropout areas, few guttae, and the left eye also shows more numerous guttae. Now, this is a case of fuchs with non-confluent guttae. Most of the cells in between the guttae are of normal appearance, and this image, even though because of guttae some areas show a dropout area, this can be analyzed, and this is quite reliable. So in this particular patient, because the cell count is decently good for a 72-year-old, we'll just go ahead with a cataract surgery alone, and no need for surgical intervention in the form of keratoplasty is needed in this patient. A few more examples. This is a patient who's a 53-year-old female. The corneas are compact and the patient has cataract, significant cataract, and you see more numerous guttae here. Now, what about the cells in between the areas of the dropout? The count is 1476, which is like borderline. There's another patient, patient 4, who is 61-year-old female. Corneas are compact, the patient has cataracts, and look at how much of abnormality we see in the endothelial cell layer. In both these patients, the cornea is compact, there's no edema, but these patients run a risk of corneal decompensation. So specular microscopy, when it is in the analyzable grade, we can assess like what exactly is required for the patient, whether cataract surgery alone will do or whether the patient requires a combined surgery. So in a case like these two images, we will go ahead with combined surgery along with the cataract surgery. Specular imaging also helps in planning for cases which would be suitable for DSO or DWEK. Now, this is one case where we had a plaque of a DSCEMET membrane thickening, and we see more of pigments in the central cornea. So in the central cornea, the image is non-analyzable because of this reason. However, if you look at the peripheral part of the cornea, by just asking the patient to look down, you can get the specular images from all different mid-peripheral areas, and you can see how much is the endothelial cell density reserve in the periphery. In this patient, the cell density reserve is 2,300, which is pretty okay. As per the guidelines, what is recommended for patients who can go for DSO or DWEK, peripheral clear cornea should at least have an ECD of more than 1,000 cells per millimeter square. So in this specular microscopy gives an idea, even though the central area cannot be analyzed, from the peripheral area, you can determine which cases will be suitable and which cases cannot. Other applications are differential and accurate diagnosis of an endothelial disorder. Now, there are many endothelial disorders which can be confused with Fuchs endothelial dystrophy. Sometimes clear-cut cases of pseudophakic corneal edema get labeled as Fuchs dystrophy, pseudoexfoliation, angle closure glaucoma, chronic uveitis. All these can mimic and can cause corneal decompensation. Specular microscopy will help in making an appropriate diagnosis in these cases. Let's see one example. This is a patient who has a history of decreased vision since 2 months in the right eye. The eye is pseudophaking in both the eyes, and right eye has corneal edema. The right eye pachymetry is 619 microns and left eye is 554. This patient was diagnosed and labeled as Fuchs endothelial dystrophy. Now, when we look at the specular imaging, right eye is not obtainable because obviously there's a corneal edema. Left eye shows a picture like this. There's an increased pleomorphism and there's an increased cell area. Now, this is not Fuchs because we don't see guttae, which are a hallmark feature of Fuchs endothelial dystrophy. This is a clear-cut case of pseudophakic corneal edema. Probably the iatrogenic factors have led to a more rapid cell decline and contributed to corneal edema in the right eye. Another case, this was a case having a poor vision. The right eye has a vision of 2320, left eye is 2020. Both eyes have a primary angle closure glaucoma. The patient has a cataract and the peripheral focal edema. Now, this is again labeled as Fuchs endothelial dystrophy because on the specular imaging, you see dropout areas. Now, quite often, the endothelial pigments are also seen as dropout areas. So it is important to understand what is Fuchs and what is non-Fuchs. This kind of corneal decompensation can occur in post-PI in angle closure glaucoma patients along with pigments, and these need not be confused with Fuchs endothelial dystrophy. Posterior polymorphous corneal dystrophy is by and large one dystrophy which can be unilateral or bilateral. Endothelial imaging in these cases reveals a low endothelial cell count and an increased mean cell area. So it is important to image these patients when we see them in the clinics. This is a patient who was a 25-year-old and shows bilateral involvement in the form of band and vesicles. And if you look at the specular microscopy image from various parts of the cornea, you can see the low cell density and increased mean cell area, which for this age, 770 microns average cell size is not normal. It is much higher than what it's expected to be. This is another patient, a 35-year-old patient who had serpentine band-like pattern and posterior polymorphous dystrophy only in one eye. And many of these patients also have a steep cornea. Sometimes they get this labeled as keratoconus. So it is important to recognize this entity and do a specular microscopy. Also because specifically if you're wanting to plan a cataract surgery in future, it is good to know what is the endothelial cell reserve in these patients. So we can see the right and left eye comparison, left eye being normal, shows a normal cell count for a 35-year-old, but the right eye being affected by this dystrophy, the cell count is 1,176, which is low compared to what is expected to be from the opposite eye. This was a 32-year-old female with essential iris atrophy variant of IC syndrome. In these patients, very often we see a very normal crystal clear cornea in the center, but most of the changes have happened in the iris and the peripheral cornea. And when we image from different parts of the cornea, we see a picture like this where we see a dark light reversal pattern. And this is quite common to see, and it is very important to image these patients in different gazes to know the extent of involvement and the area of abnormality on the endothelium. Now, for monitoring of the health of the graft, both PK and EK, it is important to do a serial specular microscopy. This helps in knowing how well the graft is doing in the long term. Now, the top pictures show the specular microscopy images of two patients who were 10 years post-DSAEK. The top left one shows a count of 1623. Whereas if you look at the right specular image, the cell density is 1020. But look at these endothelial cells. These cells are highly abnormal. They are the average cell size is more, and there's a lot of pleomorphism. Now, the same patient, when the patient with a healthy-looking endothelium to have a crystal clear graft, but the one which had increased pleomorphism, this patient landed up in the 11th year with edema, or late donor failure, or the endothelial failure. So, to know the status of the graft, it would be good to monitor the serial endothelial specular microscopy in all grafted patients. What about the relevance in eye banking? The imaging helps in obtaining objective assessment of the donor health status. Donor cornea allocation for various surgeries depend upon the endothelial cell density guidelines. In general, what is followed and practiced by the eye bank technicians, and this is recommended, is about 2,000 cells per millimeter square are the ones which are suitable for PK graft. About 2,200 is the criteria used for DSEK, and 2,400 cells per millimeter square is usually for the DMEC, because just by virtue of nature of the surgery, these are the rough ECD guidelines followed by the eye banks. Thank you, and any questions are there? I can take them up now.
Thank you, Dr. Sunita. That was a beautiful spectrum of the endothelial cells seen in various disorders. Two questions from my end. One would be that what would be the usual cases where you would do a pre-op specular microscopy regularly before you take them for surgery, and especially in Indian scenario where you have a different spectrum of fugues that we see as compared to the Western population. And that would be my first question. If you could answer, then I'll take up the second question.
Yeah. So for all endothelial disorders, my practice is to do specular microscopy in all patients, because it also helps you to understand what is the primary cause of the pathology, distinguish them, and also have explain the patient, and also prognosticate what to expect after the surgery. So in all endothelial disorders, I would be doing specular microscopy.
And my second question would be how reliable it is when we say that in studies, especially that we read that the pre-op and the post-op of pre-EK and post-EK specular microscopy was this much percentage loss, and this, how reliable it is when we know that the specular microscopy would vary, even the readings would vary from periphery to center and in various zones.
No, essentially, when we do the specular microscopy, we are targeting that we get the center endothelial cell count. So more or less, that will be pretty much precise. Obviously, there will be some bit of variation, and that is what I was highlighting. So when you get a very crisp image, the endothelial cells are clearly seen. The variability is not more than 5 to 6%. The variability happens if you have a very poor quality image, and that is what determines this. There will be a large variation between the same person, between the same patient in the same area also. So you need to make sure like the imaging what you're doing is under standard conditions, and it is done by a trained operator who knows how to handle the microscopy, the magnification, all such parameters should be consistent. So that those parameters we have to take into account while doing for pre and post-op cases.
Quick comment from Dr. Rajesh for the same question as to what are the patients where in your clinical practice you would do a specular microscopy pre-op?
As she mentioned that, yes, to determine the type of endothelial cell disorder, like dysfunction that you have, you do a specular microscopy. But even for your routine cataract surgery, especially if you are doing complicated cases where you are doing a very hard cataract, non-dilating pupil, just a slit lamp examination, you may not be able to pick up looking, unless there are significant guttate. But having an idea about what's the cell count like can definitely give you some, it can prognosticate, you know, if there is a risk for corneal decompensation following the surgery, or whether you need to take extra precautions during the surgery to ensure that you don't have a pseudophakic bullous keratopathy following the cataract surgery. So I think wherever you feel that you need a complex surgery, it's always better to image the endothelium and have a baseline count. And that definitely helps you, because if you do a complex cataract surgery and you knew that the patient had a good endothelial cell count preoperatively, you know that if you wait for 8 to 12 weeks, this cornea is more likely to recover. But if somebody had borderline cell count and you do a complicated surgery, lands up with a corneal edema, then maybe even if you wait for 3 months, there is a possibility that that cornea may not recover. So then you can consider intervening much earlier. So that way it can definitely help you.
Question to all the faculties, that when you're choosing your tissue for endothelial keratoplasty, how much importance do you give to the specular microscopy, and what are the other factors you would take in, especially in patients of EK? Dr. Rajesh?
I think the points, the cutoff values, what Sunita has mentioned, I think that's fairly valid. So for me, for my DMEC cases, if it's 2,400 or more, I'm happy with that. And yes, at times, even pseudophakic tissues with that kind of cell counts, we have managed. Just that you have to minimize the trauma when you're doing the surgery, either when you're preparing the donor or you're inserting, you have to ensure that you take care. So you can have pretty good results.
Anything with the age factor also apart, and the time of preservation apart from the cell count?
I think most of the points have been very nicely highlighted in these cases. Few important things has to be assessed apart from the total number of cells, maximum number of cells. As Sunita talked about, the morphology of cells are very, very important. If I'm doing a specular microscopy of donor, or if I'm doing for a patient also, the one most important critical point which I like to see the CV or a coefficient of variation, because that gives you an exact assessment of the functioning of cells. The CV normally in a younger patient will be less than 30%, which is a good cellular morphology in these cases. Anything more than 40% will not be suitable for the surgical for a DSAEK or DMEC as such. So I think age is definitely a criteria, but if cells quality are good, as Rajesh says, yes, why not to use them? Because we do require all cornea to be suitable for surgery. As far as the first question goes, like, as if I have a specular microscope with me, I would like to use that microscope for all cornea procedures, because it's mandatory to do a specular microscopy for every type of procedure, what we have, right from the, refractive procedure to cataract or a cornea procedure, even for doing some sort of a PRK or even doing a CXL, you have to do a corneal endothelial mapping in these patients. And this is a sort of a diagnostic. Then we have a serial endothelial pictures has to be assessed for looking for a prognosis of a disease, its progression. So it is a mandatory tool nowadays for all cornea people working there. You can't say only these are indications. Maybe it has to be used for almost like LCD or autorefractor. So this is a mandatory tool for us now for every procedure.
Thank you, Dr. Tatian. And we'll go on to the next talk from this discussion. We'll go back to James. I hope his audio is working well now. Dr. James will be talking about what happens to corneal edema over time. I think, James, we have some issue with your thing. We'll skip your talk and we'll go on to the next one, probably.
Long distance audio.
Yeah, we were looking forward to your talk, but I think we'll go on to the next speaker, and that would be Dr. Rahul. Dr. Rahul will be talking about the next section into this webinar today. The session will be, now we'll be talking about the Fuchs endothelial corneal dystrophy, and it's good to have him. We will have a lot of discussion about this. Dr. Rahul, we'll start with your presentation.
Can you hear me okay?
Yes, you're fine.
Okay, great. So yeah, thanks for having me. Enjoy being part of this. Good afternoon, good morning for those of us here, and good whatever it is everywhere else. I'm following up some great presentations here, so I'll try to skip over some things that have been already discussed, but based on the last talk about endothelial cells, especially in Fuchs dystrophy, I think this ties into my talk very well. We'll go into a little bit of basics about Fuchs dystrophy before we get into some of the more detailed discussion about it in this 10-minute presentation. The demographics of Fuchs really are that it's about 4% population prevalence throughout the world. It's globally prevalent. There are regional variances, which we'll get into in a short while. Most commonly, it's seen in patients over the age of 40, though there is an earlier onset variant with a slightly different genetic profile. There are more females affected than males. And a very interesting study that came out of Harvard just a few months ago looked at why this may be. And the theory that was proposed was that perhaps ultraviolet light affects eyes differently in females and in males. Interesting study for those of us who are inclined to read more. The citation is below. This is the most common corneal dystrophy requiring transplantation globally. Symptoms, of course, are decreased vision, but more importantly, we see glare and decreased contrast sensitivity. We looked at variables requiring endothelial transplantation in patients with low cell counts, but one thing we don't often realize is that patients are often affected at earlier stages than we give it credit for, just because of the prevalence of guttae in the center of the cornea, which really affect their vision. So in some cases, we are moving to surgery at an earlier stage, especially with the advances in surgery that DMEK can afford, with a faster recovery and the potential of extremely good vision recovery. There are often fluctuations in vision, and this can be some of the most troublesome signs early on in the course of the disease, with patients waking up with worse vision due to the decreased surface evaporation that occurs while their eyes are closed during sleep. And of course, in the more advanced stages, you can have pain due to ruptured bullae from swelling in the corneal epithelium. This has been localized in most patients to chromosome 18, and what's been discovered is expansions of the transcription factor 4, or TCF4 gene. In particular, the intron CTG repeats anywhere from 10 to 2,600 times in patients. Most commonly, it's seen in repeats of over 50. This is a very interesting finding and one that's been studied quite a bit. And one interesting notation, I had the benefit of working with our neurology colleagues at Methodist and looking at muscular dystrophy type 1 patients who also have a similar CTG repeat in a different gene. And there was some studies performed elsewhere as well, looking at the correlation perhaps in systemic CTG repeats in other genes versus those in patients who have it in the cornea. So I think there's a lot of interesting developments in this field. We see that these repeats can occur globally, and it's actually quite significant in Chinese populations and a significant association in Indian populations as well. One study suggested that perhaps the Japanese population had a weaker association, but it is prevalent globally. We also, as I mentioned earlier, there's an earlier onset variant, which appears to be due to a different gene. The clinical presentation, as we've discussed quite a bit, is that you have corneal guttae, which are collagen excrescences in Descemet's membrane. And this is the classic beaten metal appearance that occurs on the posterior cornea. They start centrally and spread towards the periphery. And the same study that I referred to earlier also looked at a mouse model where perhaps ultraviolet light exposure, which is obviously prevalent in the palpebral fissure and in the center of the cornea, may be a reason why there are genetic alterations in the central endothelium in these patients first. Guttae can be seen in other conditions. 11% of people over the age of 50 in one study do have guttae. And these are seen in other conditions, as we've mentioned, in uveitis and deposits from other conditions as well. These are pathologically identical to Hassel-Henle bodies, which are in the periphery and are a benign variant. We also see, as has been described quite nicely in the previous presentations, thickening of Descemet's membrane with deposition of collagen and extracellular matrix. But we can also see that there's increased pigmentation. So it sometimes looks like there are pigmented and non-pigmented guttae. And of course, with prolonged disease, we have corneal edema, which can then actually lead to stromal haze and subepithelial fibrosis when it's quite prolonged, such that we have some patients who, when they present with advanced disease, may not be the best candidates for just endothelial keratoplasty if they've had significant corneal stromal scarring. And then, as was discussed earlier, polymegathism and pleomorphism can be seen on specular microscopy. And these, I agree with the prior presentations and discussion with Dr. Titial, suggesting that these are quite important variables in terms of trying to assess a patient's recovery from any sort of surgery, including cataract surgery. The higher the coefficient of variability and other variables like that can affect recovery. If we look at the grading scales, there are various ways of grading Fuchs dystrophy. We have the original Kratchmer scale from 1978, which essentially includes 6 different grades, and this has been modified to a different grading scale. Instead of 0 to 4+, we can just call it 1 through 6, which I find a little bit easier. We'll discuss this in more detail in a second, but you can also see that there are other grading scales, such as the one below here from the Academy of Ophthalmology, looking at not just the original 6 grading scales and compressing them into perhaps the first 3, but adding a 4th one, which I was discussing, which occurs in very advanced stages when you have subepithelial fibrosis and dense opacity in the cornea with severe disease in the stroma as well. Now, looking at some of these cases, let's take grade 1, where you have just less than 12 scattered non-confluent gutty that you can see here. And these were described in the first cohort of patients described back in 1978 by Kratchmer. Moving on, you can have more than 12, but still non-confluent and really not clinically relevant to the patient at this stage. Once you start getting a more confluent pattern, especially in the central 1 to 2 millimeters, you can grade this as grade 3. And then expanding to a further diameter in the central cornea, 2 to 5 millimeter diameter, would be considered grade 4. And again, you have a confluent pattern. And I believe this is where you start seeing clinical signs, clinical symptoms, perhaps even at grade 3, where you start having a little bit of contrast sensitivity loss and glare in patients. And of course, grade 5 with a larger diameter, greater than 5 millimeters of corneal involvement. And then grade 6, where you can see stromal and epithelial edema. In this patient of mine, you can just see a little bit of edema off to the right of the slit beam, which is very subtle, but definitely leads it to a higher grading scale. And of course, a more advanced pattern of edema, as you can see here, which is quite obvious and not easy to miss. We talked about the traditional risk factors in Dr. Sunitha's talk for decompensation, and we can review that here: endothelial cell count less than 600 or pachymetry of greater than 640 microns, or the presence of any edema. However, we know again that sometimes these traditional risk factors are not very meaningful. For example, endothelial cell count, as was discussed nicely, can be limited, especially centrally when there are significant gutty. And of course, we know that the pachymetry in patients can vary dramatically. If you don't have the baseline pachymetry, you really can't comment on whether a pachymetry is abnormal for a patient or not. So one recommendation that was suggested was looking at corneal tomography and Scheimpflug imaging. And this is a great study that Dr. Patel from Mayo Clinic has been talking about. This is again looking at Scheimpflug tomography risk factors for 5-year significant progression of Fuchs. And he brought it down to 3 important factors, 2 of which were significant on multivariate analysis. The first one was loss of regular isopachs. As you can see on the bottom right image here, you don't have a regular pachymetry pattern in the cornea. So where you have irregularity, that leads to a higher risk for progression. Second is displacement of the thinnest point of the cornea, which as you can see also in the bottom left image, relates to the higher risk for Fuchs, because as we know, the thinnest point of the cornea generally should be in the center. And then finally, the focal posterior depression, even though this was not significant on multivariate analysis, it's really tied into factor number 2. And you can see that on the bottom right image. And I consider that to be very helpful as well, where you have, instead of elevation in the cornea in the posterior surface, you actually have depression. So it actually pushes back with a negative finding on tomography measurements. As you can see from patients of mine here, we have a patient with quite thick cornea here, as you can see from a Galilei dual Scheimpflug imaging. Corneal pachymetry was 587 centrally. However, there were pretty regular patterns of posterior elevation on the bottom right image and on the bottom right of the left image. And then also the pachymetry map, which is the top right image on the left hand of the screen, shows that there are actually pretty concentric rings of pachymetry with fairly central location of the center of the central thinning portion. One thing I look at in the Galilei as well, which I found to be helpful, is total corneal wavefront. And that's the very bottom right image, where you can see 0.5 microns of root mean square corneal wavefront aberrometry. And I think this is one thing that we can highlight. We're going to see more aberrations in these corneas, and that's what I like about this imaging. Whereas if you go to this next patient, the central pachymetry is actually only 490 microns. This patient must have started out with a very thin cornea, and this is not a post-refractive case either. But you can see in the left-sided images on the bottom right of those images, you can see that the posterior elevation is a little bit atypical, where you have a depression on the right. You can also see in the upper image just above that, that you have a little bit of nasal displacement, temporal displacement of the thinnest pachymetry. And then if you look at the corneal wavefront, you see an RMS of 0.64 microns. And if you note carefully, you see a significant increase in horizontal coma with a slight increase in vertical coma. And again, this is due to the pattern of edema and the irregular isopachs, especially horizontally in this patient. So I think these are factors that we can look at as we dive into details into the shape changes in the cornea from early Fuchs disease. Moving forward, cornea guttata is the strongest association with progression to post-phaco, from the progression post-phaco to transplantation for any cause. So again, cornea guttata is very significant. Fuchs is, again, the most common cause of corneal transplantation worldwide. In the US, we see that as well, where 36% of the almost 47,000 transplants performed in 2016 were for Fuchs. But if we look at the India data, we can see that the most common cause is actually for infectious keratitis. This is for all transplantation. If we divide it up into endothelial keratoplasty, we don't have national data for India, but if you look at two centers, prominent centers, Adisha Eye Hospital, where Dr. Basak presented 600 eyes just last month, showed that 43% were for pseudophakic bullous keratopathy or post-cataract corneal edema, and 36%, or a decreased number, were due to Fuchs. And when I spent time with their clinic a few years ago, it reminded me that a lot of the post-corneal edema from cataract surgery is related to contaminants from some of the products that are used intracamerally during surgery due to unregulated products sometimes being used. And if you look at Dr. Schroff's data, 261 eyes over a 2-year period, we can see that even a larger majority were for pseudophakic bullous keratopathy with a smaller amount for Fuchs. So again, the distribution is maybe slightly different, but we do see Fuchs present globally everywhere. And certainly globally, the leading cause of corneal transplantation. One thing I'd like to point out in this slide, this is a nice summary of global transplants in 2012. You can see that behind the US, India had the largest amount of transplantations nationally around the world after the US. So definitely a large rate of transplantation. However, if you look at per capita, it is very small. And again, that's because of the population of India being so large. And once again, this is a nice pictorial of the differences in the reasons for transplantation globally. Once again, US, it's really Fuchs dystrophy. Many parts of the world, it's keratoconus. And of course, in India and some of the South Asian, Southeast Asian countries, still infectious keratopathy for global transplantation, if you include PKP and endothelial keratoplasty. And finally, I won't go into surgical management because that's going to be in one of the upcoming talks, but we see that we have great surgeries now that avoid penetrating keratoplasty, such as DSAEK and DMEK, which afford a faster recovery with lower rates of rejection. And of course, DMEK being a slightly newer version than DSAEK, with less rejection seen in DMEK eyes, and of course, less refractive changes due to less thickening added to the cornea in DMEK eyes. And happy to take any questions, but thank you for your attention.
Thank you, Dr. Rahul. That was completely a wide view of how does the Fuchs present in clinics in your clinics. I would just take in some comments from Dr. Praveen and Dr. Tatyar as to what kind of Fuchs patient do we see in Indian perspective in your clinics.
Well, interestingly, it seems as if most of the fugues that we see in India are probably also diagnosed as PBK because they come to the clinic after they've had their cataract surgery elsewhere. And it's only when you look at the other eye that you realize that it's fugues and reclassify them. Would agree with what Dr. Pandit said, that fugues doesn't seem to be as common in India as it is reported from the West. And I would request Sunita to comment as well. Sunita has published data from LVP2 about the relative distribution of the different diseases for which endothelial keratoplasty was done. Sunita, would you like to comment?
Yeah. So when we look at this data is a little long back, almost 10 years ago, when we looked into the EK indications. So in our patient population, the patients who underwent EK at our center, 30 to 40% were 40% rather were PBK. Only 10% were fugues. Failed graph, failed therapeutic, and optical were a significant number, 30-40%, and rest were miscellaneous other indications. Now we looked at our more recent data. Now this is based upon the EMR study of the last 5 years. Again, the trends have not changed much. So we again have more of PBK more. It's similar kind of trend. 30-40% is PBK. 10-15% is fugues. Now fugues has increased because I think now when DMET, we are operating more because in the early stages also when we see significant gutted which are interfering, we tend to do DMET because earlier when it was DSAEK, we were little bit more conservative for just going for only cataract surgery, probably DSAEK and PK. And that data was 10 years ago. But now with the DMEC, I think we have more numbers. So the patients who are undergoing keratoplasty have increased from 10% to 15% as per the recent data. But again, it is not matching the PBK. PBK is still more than fugues.
I think the distribution that you have shown is exactly what we see in Schroff's last 5 years data. Fugues was 10% and PBK was about 47% of the patients. Second thing which was very interesting was also the gender distribution. As Dr. Rahul was saying, the more of female male ratio for fugues in Western, we saw the patients which underwent surgery was almost equal. Male versus the female distribution was 1:1. Any comments, Dr. Sunita?
I just want to add one more thing. In our database, we also looked at how many of the fugues actually required a keratoplasty. This is again recent data of the EMR, where patients were diagnosed with any stage of fugues at any stage, and how many actually required transplants. So that is again only 10% of the fugues what we see require transplants. Like it's not that majority were coming with decompensation. Many were early fugues, so they did not require transplants. And this is as per the last 4-5 years data, what I'm telling you. So 10% of the fugues require transplants.
I think I also agree to facts which have been brought about by Praveen and Sunita. We do see a similar pattern in northern India. What Nidhi was talking about. We have a data from RP Center that is people who have undergone EK or endothelial keratoplasty. Of that, around I think 15 to 18% of cases were diagnosed to have a fugues in these cases. But I do agree what Praveen is saying, like many of cases will come as a bullous or a endothelial decompensation after cataract surgery. And very difficult to pinpoint what would have been a pre-op diagnosis for these patients because we don't do a good examination or specular microscopy for cataract patients across the country. In that regard, then we'll have more diagnosis of fugues patient, which is now increasing, as rightly said, because of the success of endothelial keratoplasty in this country also. But very surprising that we have such a significant number of cases reported by Dr. Basak. And talking to him, he says maybe people from eastern part will have a more endothelial dystrophy, which I'm not very sure unless we have a well-planned study across the country to see. As you are saying, the sex distribution also has to be reassessed. That can only be possible if you do a good community-based analysis for these patients. Then we'll exactly know what type of pattern we have in terms of fugues patients are concerned. But surgery-wise, the number of fugues patients are increasing because we have also become more bolder to do surgery for these patients in early stages.
And also not all patients with fugues except surgery, a lot of times you see patients with Fuchs who are still 6'9", and even if you discuss with them the surgical option, they offer to wait.
Yes.
And so that's why whatever number of patients we are seeing compared to the West, where they are more aggressive in terms of doing endothelial keratoplasty, maybe in our part, we may be seeing cases, but not all patients progress to getting a DSEK done. Maybe they wait longer. And the male-female discrepancy also would be something to do with the society system. That means the men maybe get more preferential because they are working and everything. The women are at home. So even for an elderly lady, 55, 56 years, they say, oh, she doesn't read, she doesn't require. So they offer to wait and they get it done later.
I think sometimes people may be over-diagnosing a Fuchs patient now. Even patient with other causes of endothelial decompensation are labeled as a Fuchs sometimes. That also we have to look into.
Thank you for those comments, and I hope, sir, that social status of women not getting a specular that will change with time. With so many women coming even in ophthalmology, we should screen there also. So we'll go on to the next talk. We have skipped Dr. James' talk for now. I think we'll bring him back after Dr. Praveen's talk. We'll take Dr. Vikas's talk now on early PBK. Over to you, Dr. Vikas.
Yeah. Okay, so it's visible? My screen is visible?
Yes, your screen is visible.
Okay, fine. Thank you so much, Nidhi. And it's really an amazing webinar going on, quite informative. And we have already discussed that it is the pseudophakic or aphakic bullous keratopathy that we see more in almost 4 to 5 times more than what we see for Fuchs. So Nidhi told me to describe what all clinical things that we see. So I'll just take you through a few cases. Okay. So pseudophakia cataract surgeons, they love to see the cornea like this. Clear, compact cornea, 20/20 vision. Compact is very important, and we have already discussed why. Because in cornea surgeon clinic, they do see corneas which are not compact. And why these corneas are not compact? Dr. Lehmann just shared this beautiful photograph, because this is the endothelium that's not functioning. So let's see why the endothelium is not functioning in these corneas where the cornea is not compact. So we have broadly, we can classify it into 3 knots. There are either endothelium is not in place, it doesn't have an access to the stroma where it can actually dehydrate it, or endothelium is present but was not good enough since the very beginning, or the third is present, was good, but could not stay healthy after the surgery. So let's take it one by one. What is the meaning of endothelium not in place? Descemet detachment. With after cataract surgery, we do see come across these kind of things. If descemet membrane detachment is not managed well in time, then it ultimately can lead to pseudophakic corneal edema, and if that also is not managed well, then can lead to pseudophakic bullous keratopathy. So here the endothelium is not there; it doesn't have an access to the stroma so that it can actually function. So it's not in place. Sometimes I remember one of the cataract friend of mine, he was sharing that he was doing a cataract surgery and suddenly he saw that whole descemet membrane detached and got aspirated into the IA probe. So that also happened, and we had to do an endothelial keratoplasty for that patient. So second scenario is endothelium is present but was not good enough since the very beginning. So sometimes your cataract colleague, they call you and say that, see, this patient has landed into PBK, although the surgery was totally uneventful. And if you ask them how was the cornea look like pre-op, and they'll say no, it was perfectly fine. It was clear cornea, just NS2+, and there was hardly any energy. I don't know why this has landed up into this. So there are possibilities that they might have missed this unhealthy looking endothelium, which Dr. Pandit just now pointed out. They might have missed the Fuchs, and even if the cells were less, although clinically it was looking fine, but it could not tolerate that particular energy, and lower cell count ultimately ended up into the pseudophakic bullous keratopathy. Another such scenario can be an ICE syndrome. Here again, the endothelium is there, it's present, well in place, but it's not good enough to pump the whole fluid out of the stroma, and any surgery will ultimately can lead to PBK or pseudophakic corneal edema. The third scenario would be endothelium is present, good enough, but could not stay healthy after the surgery. What is the meaning of that? there can be two different types of damage that can happen to the endothelium. One is mechanical damage. Let's see, these kind of patient where, phaco energy was, you do a PBK in a very hard cataract, lots of phaco energy, or you have to somehow do a phaco in anterior chamber, can land up like this. Or a difficult SICS or ECC where the endothelium got mechanically damaged by either phaco energy or the nucleus or any instrument that had been taken inside the anterior chamber. And sometimes this patient, I remember, had undergone corneal tear repair, then cataract surgery, then had an RD, underwent an RD surgery, silicone oil was removed. Ultimately, with so many surgeries, endothelium could not, handle that stress. So there was a cumulative endothelial cell loss and ultimately ended up into decompensation. And this was mechanical damage. What other mechanical damage can have? This patient was typically had undergone cataract surgery, very young patient, undergot cataract surgery 20 years back, was fine, doing fine, but the last 1 year, slowly, progressed to miss of vision. So there was TCIL that was placed in AC, and then obviously it will keep on hitting the endothelium. These lenses I have seen, during my endothelial keratoplasties, and these lenses are implanted even before I was born. So many times I had to, call my senior colleagues and ask them what kind of lenses is, how will I remove it? Do I need to cut the haptic, or, they can come out? So these kind of lenses, but it's because of these lenses only the research has happened, and now we are enjoying such beautiful lenses. So fortunately, we have endothelial keratoplasty to take care of. So these lenses, which are older design lenses, in Indian context, iris claw lens, specifically the older design, you can see here, if the claw or clip is on superiorly, only at one end and not in the center, then it will keep on oscillating between the endothelium and the iris, and chance of hitting the endothelium and going into PBK would be more. Although the newer design, the later design where the clip is in the center, they tend to be innocuous and hardly do anything to the endothelium. And Kalman 4-point fixation, ACL, overall it's a very good lens, but in case you misdiagnosed or you didn't calculate the diameter, so it has to fix at 4 points. Suppose you take a lesser diameter ACIL, it will keep on wobbling or keep on hitting the endothelium in the AC. Or, malposition, it's a vertical position, no PI. So if the lens is fine, but you could not implant it well, at that time also it can land up into endothelial decompensation. So these were mechanical damage. So there was mechanically the endothelium was damaged by either instruments, phaco energy, lens per se, all those things. So can there be a chemical damage also? Yes, I remember a surgeon who used to give intracameral moxifloxacin at the end of cataract surgery, and once inadvertently he had injected preservative containing moxifloxacin, and he had TAS in 20 eyes. And 18 out of them, 18 we had to do an endothelial keratoplasty. So I'm just trying to highlight that if the task can be really detrimental to the endothelium and can land up, you can see the presentation where there was a history of TAS, and now we are seeing is pseudophakic bullous keratopathy or corneal edema. So these were how they present, but if the patient doesn't have a history of cataract surgery, even then the patient can patient present with that? Okay, so this lady had undergone phakic IOL around 30 years back, and this is how it was in right eye, and ultimately ended up into the pseudophakic corneal edema in the left eye. You can see that, and this was the lens which was explanted while doing a DSAEK. Can you think what is this? Can you just have a wild guess? So I'll just show you what it was. I hope it is okay. So this lady had undergone. Oh, okay. So this was actually a TAS secondary after ICL. So she had undergone ICL surgery, following which she had TAS, and ultimately ended up into the pseudophakic bullous keratopathy. You can see that. So we'll call it phakic and aphakic bullous keratopathy. It's not moving. What happened? So I think I'll skip it. So and then I think after this I have one more presentation where I just a couple of weeks back I saw one patient. She had undergone a phakic IOL, which was of acrylic phakic IOL, and intraoperatively there was some issue and it got flipped in a reverse position, and surgeon had to flip it in the AC. And although she could do that flipping well and the lens was well in place, but ultimately the patient landed up into the, you can see this, corneal decomposition. We recently have done her DMAC. So, you know, bullous keratopathy can be pseudophakic, can be aphakic, and can be phakic as well. And what is the pathogenesis? We have already seen, and Dr. Lehmann has already pointed out, endothelial pump failure. It goes, fluid goes into the cornea, and then if it gets collected and under the epithelium, there will be microcysts. They merge each other and form bullae. So initially you have edema. If you know it keeps on going, it lifts the epithelium and cause bullae formation. So in edema, there will be only dimness of vision, but you have bullous keratopathy, then you'll have pain, redness, watering, all those things. So you need to have understanding when you see a patient of pseudophakic bullous keratopathy, you need to understand why it has happened, what is the main issue, so that you, when you are planning your DSEK, you might need to plan additional surgery as well. Thank you so much.
Thank you, Dr. Vikas. Extensively covered all the causes and nicely shown what are the causes. Just one comment from you as to what are the patients and what is your guidelines for everyone, participants, as for doing gas versus an EK in patients of DM detachment in early PBK?
So I generally, for DM detachment, you are asking what do you use, gas versus any other air for DM detachment, right?
In patients of early PBK where you would see DM detachment, would you prefer to go for a gas bubble, or what would be your guidelines to go for an endothelial keratoplasty in them?
Okay, so if you have a DM detachment, you'll definitely, I'll definitely use air or do a descemetopexy first, because many times that endothelium or descemet that has been detached, that has a healthy endothelium. And when you stick, we have patient where we have done descemetopexy even after 6 months after the primary cataract surgery, and sometimes that needs twice or thrice rebubble and settles well. But yes, if you are sure that DM is attached well and stroma is not clearing, you'll have to go for endothelial keratoplasty.
I think Vishal, what Vikas is saying is absolutely correct. We have to try some sort of a pneumopexy for all these cases with chronic edema after cataract surgery. And some of them can have a descemet membrane detachment. We have had patients even after 3 months, 6 months, even 1 year after edema, we have successfully attached detachment. But it's very critical to see the other eye also. If other eye has a Fuchs disease with very significant damage, so these cases or these endothelium doesn't survive after a pneumopexy also. So you might try this also, but we have to really take these patients for EK subsequently, and accordingly we have to counsel these patients. So it will depend on the other eye disorder also sometimes.
Yes, sure.
Thank you, Dr. Chatyal and Dr. Vikas. We'll go on to the next talk with Dr. Praveen talking about PBK, late presentation of PBK. Over to you, Dr. Praveen.
Thanks, Gandhi, and lovely talk by Vikas as usual. Covered most of the findings and challenges after cataract surgery when you have corneal edema and you're considering endothelial keratoplasty. So what I will focus on is pseudophakic bullous keratopathy that tends to occur a little later. And this is the typical scenario because most patients who present to you with corneal edema, especially if you're in a referral practice, have gone through the gamut of all kinds of treatment that the referring doctor has already tried before they finally refer the patient to you. So you will see significant on several different kinds of presentations, but there are a few important things that you should note and you should look out for in a patient who comes to you with PBK. For example, this is a patient who presented again several months after the initial cataract surgery. What you will notice in several patients of PBK, you will see a lot of them will have stromal folds. You will see that several of them have DSAEK folds, and you will have epithelial edema as well, like in this case. OCT, again, is really useful in cases of PBK And the early changes that you will notice is a thickened descemet membrane, and you will also start to see irregularity of the corneal epithelium, as well as the formation of some microbullae, where you will see clear spaces within the epithelial sheet. Patients like this usually do very well when there is no significant amount of stromal scarring, and postoperatively, they usually tend to resolve very quickly, and this is post-op day 1. And sometimes, even though you might miss this in the initial period, this is post-op 4 months of the same patient, there might be some amount of surface scarring because of inflammation on the surface that tends to cause the scarring, and this really does not go away, but it probably also does not affect visual acuity to a significant extent once the epithelium has relayered adequately as well. And that's post-op 4 months. You'll see that the cornea is almost back to its normal thickness after this DSAEK surgery. More severe cases that tend to present after cataract surgery, and in this case, you also will see that there seems to be some damage to the iris, and there probably was a traumatic surgery, though the IOL is present in the bag. What you will see in these cases are more significant bullae, and you will have to deal with a larger pupil. And you can see similar findings with intraepithelial edema as well on the OCT. And again, these kind of cases, this is a post-DSAEK. You do expect that you will have some residual scarring, especially in the area of the bullae. And these are cases that visual acuity might not improve to the complete extent of 20 by 20. You also have patients who present to you with a significant amount of subepithelial fibrosis along with bullae. And these are patients typically who are several years out after the cataract surgery. They've waited, or they've been made to wait before they've had an intervention, which is a bit unfortunate. But if you look at the OCT of these patients, in the periphery, you will see that there seems to be a pre-existing pathology for such severe bullae in one area. And this patient, actually, it's not seen very well here, but the patient did have a localized central descemet detachment. And what you will also see is a significant amount of subepithelial fibrosis, but most of the stroma is clear. And the OCT is again very crucial to make a decision whether you should do a full thickness penetrating keratoplasty or you should do only an endothelial keratoplasty, because if you have a very good cleavage plane, the majority of these patients do really well by taking off this subepithelial fibrosis and the epithelium. And this is the same patient 3 months post-operatively, and you'll see that the cornea is cleared really nicely. And the cornea, actually, this is post-DSAEK, has deswelled quite nicely as well. So you don't need to worry about subepithelial fibrosis as long as you get an OCT and you know that there is not enough significant scarring in the anterior stroma, and you will get a good result. In fact, in patients who have such significant scarring, as you can see with subepithelial fibrosis, you actually, during surgery, you can even do this at the slit lamp, and you can check and see if the underlying corneal stroma is clear. And the majority of cases, you'll be surprised to see how clear the underlying stroma is. And once you do an endothelial keratoplasty, you will have a very good result. The only issue is, in some cases who might have been referred to you, is if patients with long-standing PBK, if somebody is attempted to do an ASP multiple times, like you see in this patient, the post-op result with the kind of scarring that occurs in the corneal stroma because of ASP, which is actually something that is induced, is going to again preclude full visual recovery, and you need to be careful about being able to identify this too before you do surgery. The other interesting thing in cases of PBK, especially in eyes that have some sort of inflammation, is you will notice that the wound sites in these eyes tend to become very prominent. And you also see some fibrosis of the descemet membrane over the wound sites. And this is important again from the point of view of surgical planning, because you would want to avoid these wound sites when you're doing endothelial keratoplasty. And even post-op, you will see that, pre-op, you see that there is reduplication of descemet membrane, small area of detachment overlying the wound site in these cases. This is the same patient post-op 1 year. Patient is doing really well, but we avoided the wound sites to make sure that we created a new incision. And in fact, you will see that there is a bit of past that is formed between the iris and the new incision that has been created to do the surgery. And though this is DMEC surgery, you'll see that overlying the incision site, there is still a detachment. And this is something that you need to expect and avoid, because when you have a wound that is that has excessive fibrosis or scarring, especially of the posterior stroma, you can get quite a bit of irregularity, and your descemet membrane might not stick as well as you would expect to the posterior stroma. You might also have surprises like this. This is a patient who underwent a filtering surgery. Apparently, the filtering surgery, like an iridoenthesis that went wrong several years ago, and he had an ACIOL, and this patient was operated more than 30 years ago, and eventually he developed bullous keratopathy, was a one-eyed patient, so we decided that because he had this IOL in the eye for such a long time, that we were not going to touch the IOL, and instead we just did a DMAC, and that is enough in a patient who's had a lens in the eye for such a long period, where obviously the amount of corneal edema that he would have because of a stable lens probably is going to change over a very long period of time. So I would leave a lens in place like that. In other cases where you have more recent surgeries, like in this case with an ACIOL in the eye, where you have a lot of pigmentation on the descemet membrane as well, would be a good idea to exchange the lens and replace it with a new lens, either iris fixated lens or a little sutured lens. And these patients, again, they tend to do really well after you've done their surgeries for them. This is again a DMAC in that patient. There are some subset of patients after PBK who seem to have a localized area of inflammation in the eye after surgery. And again, you will see that they will have more superficial vascularization than other patients. So you're doing the OCT, you can see that there is epithelial reduplication in several areas as well. But post-operatively, this patient did really well. And you will see that the cornea cleared very nicely, including the posterior stroma. But if you look at the posterior stroma a little more carefully in the area where that patient had that source of inflammation, you will typically see there is some scarring of the posterior stroma or the pre-descemet layers. Since this is not in the visual axis, this is not going to be significant clinically, but this is something that you can expect to see in patients who have that localized kind of scarring. You also might see patients with PBK who have significant pigment dispersion, and those who have pigment dispersion, you should expect to see a lot of retrocorneal membranes in these patients as well. And you should be aware of this when you're doing your surgery, because it's not just the membrane that you take off, but also the descemet membrane in these cases. Same patient preoperatively, you can see the posterior stromal folds, and the patient post-operatively about 1 year or so later, again seeing that the cornea has cleared really nicely after surgery. So this is another patient who had TAS and inflammatory TAS, and clues to the diagnosis of TAS will again be a very prominent internal lip of the incision, as you can see right here, a dilated and a fixed pupil, potentially because there is of inflammation or a severe rise of intraocular pressure after the TAS has occurred. You also need to be careful that in patients who have had inflammation in the eye or any traumatic cataract surgery, always look for CME, because this is something that you would want to pick up at the time of surgery so that you can actually treat it at the same time as well. So this is again the same patient who had a DMAC after the initial TAS surgery. You need to be a little careful about the size of the pupil and the graft touching the IOL, and you can put a suture to reduce the size of the pupil if you think that will help you with handling of the graft intraoperatively. The other interesting aspect of patients who've had TAS is you also will tend to see some amount of higher reflectivity in the posterior stroma, the pre-descemet layer, especially in patients who tend to have a significant amount of posterior stromal folds and DM thickening. So expect this, but this again does not compromise visual acuity to a large extent, and the recovery is usually quite good as well. Other patients of TAS will also tend to have these fixed folds in the posterior stroma on the descemet membrane. These are again something that will be transient. This is a patient with a fixed dilated pupil post-TAS, and this is the same patient 1 year after surgery. So this patient did really well, and you will see that the fixed fold also has gone away without any issues in the eye. Very rarely, and there is only one patient that I've seen pseudophakic bullous keratopathy with such a thick retrocorneal membrane. You can see this is a patient who had significant amount of inflammation. Post-operatively, it formed a thick fibrous membrane, and in several areas, this is actually attached to the iris. So once you take this off, you can see the rest of the anterior chamber pretty well, but also remember that there's a descemet membrane behind this. Once you take off this retrocorneal membrane, that you will need to take care of as well. Sometimes you also will see patients who have had a ACIOL that has been implanted more several years ago and doesn't seem to impact vision very much. But those patients who've had a recent surgery and have an ACIOL in the eye, it probably is a good idea to exchange the lens and replace it with a lens that is either behind the iris or in the sulcus, or a lens that is sutured to the sclera. As you can see here, this is a lens fixated with the Yamane technique, and this patient is doing really well about a year after surgery. Some of the longer term changes that you can see in PBK, like in this case, post PK, then post failed graft, you see that this patient has spheroidal degeneration here as well. This again does not probably impact your surgical procedure, but it can lead to symptoms post-op, can lead to epithelial breakdown as well. On the OCT, you can make out the spheroidal degeneration, that it tends to block out some of the OCT, and that is probably one of the ways in which you can diagnose that this patient has spheroidal degeneration. This is a patient that we saw quite recently, again, a patient with PBK long-standing, and because of the PBK, he also had a spastic entropion, and because of the lid, a constant abrading the inferior cornea, he also developed BSK over several years. And again, a short sign to diagnose BSK is to do an OCT, because the calcium will completely filter out the OCT, as you can see in the lower OCT here. So you can combine doing the surgery along with doing BSK removal using EDTA, either sodium or potassium, and you'll see that this is the DSAEK surgery that we did recently, and you see that the BSK has cleared out completely. Sometimes you also have patients with PBK who have pigmentation on the Descemet's membrane, and this is an indication of loss or denuded areas of the Descemet's membrane. So in these cases, it probably is not a good idea to stain with trypan blue during surgery, because the stroma tends to get stained as well, and you will have a slightly more difficult time visualizing the anterior chamber. Other surprises that you might get is, this is a patient who had cataract surgery more than 2 years ago. He came to us with PBK that started about 6 months before he came to us. And we looked at him a little more carefully. If you look at the inferior angle, this patient actually has a nuclear fragment that is left behind in the angle, and the nuclear fragment over time can actually cause endothelial decompensation. That's the fragment on OCT. Sometimes this is the surgery and how the nuclear fragment actually was visible during surgery. So you can see that this can be a significant cause of corneal edema over time as well. Sometimes the nuclear fragment might be present in the anterior chamber, but the cornea might be relatively clear with early edema. This patient had a decent specular count. So we elected to wait for a little while, but then the patient was lost to follow up. And when he came several months later, the edema had become so much more significant. And the other side effect of leaving a nuclear fragment in the inferior angle is the development of synechia, as you can see here, because of the inflammation. And this again will need to be handled at the time of surgery as well. I'd like to end with one case. This is not exactly PBK, but this is actually caused by one of those infernal iris implants. We've seen several of these patients, and these are devices that uniformly and universally should be banned. This is the patient's sibling who had the same kind of implant inside the eye. You can see a lot of inflammation around the limbus, and this patient also has developed uveitis as well as early corneal decompensation and will require surgery pretty soon. This patient that I showed you earlier also had LASIK and had interface fluid in the LASIK flap, but then they can be managed quite easily. Just to show you the side effects of having implants in the eye, not just the IOL, but all of the implants also don't seem to do a good job inside the eye. This is her post-op 3 months, and she did pretty well. So just to summarize, remember that the longer the edema is present in the eye after PBK, it usually takes longer to clear and can lead to structural changes as well. Always look for the position of the IOL, vitreous and nuclear fragments, because these might be X factors that change your surgical approach. Expect a retrocorneal membrane in eyes that are post-inflammatory. Also look for CME in these cases, because you might need to handle that. On subepithelial fibrosis, always look for it on an OCT, because you can get rid of it at the time of surgery, and most of these cases have very good visual outcomes. Also note previous incisions so that you don't overlap your graft with your previous incisions, and you create new incision sites when you're doing your surgery. And if you have some residual scarring on the anterior or the posterior surface, this usually improves over time, and does not affect vision quite significantly unless it is very dense and causing a change to the corneal contour. Thank you very much.
Thank you, Dr. Praveen. I think almost saw all the cases we have seen over the years of PBK on your presentation. There's a question which is coming up on the chat box as how much amount of time would you like to wait before you take a patient of TAS for endothelial keratoplasty?
Well, as long as there's no inflammation in the eye, you can take the patient up, because TAS again is of various types. You have non-inflammatory and inflammatory TAS. Inflammation is usually generated because of uveitis that occurs at the time of surgery. Non-inflammatory TAS is just because, like Dr. Pandit mentioned, you just have a change in the pH of the solutes that are used inside the eye. So that doesn't lead to inflammation. You can do surgery earlier. But the key is to wait for inflammation to subside before you do surgery. And most of these cases do really well after endothelial keratoplasty as well.
Any comments from the panelists?
I think, as far as my experience goes, the TAS, like doing early surgery sometimes can be a real challenge for us, as Praveen talked about, especially if you have a lot of inflammation and the entire eye is filled with the pigments. And I had one patient where I had to operate within the first 3 or 4 weeks with a lot of pressure from the surgeon. And as soon as I entered the antechamber, entire eye was black and brown because of the pigment release. And one other important factor in TAS patients are they do have glaucoma, which is very difficult to control sometimes because the entire trabecular area is also inflamed and damaged. So even you do a successful EK in these cases, the glaucoma part may still persist. So that has to be controlled very, very nicely. I have a patient who had a beautiful EK done, but subsequently there's an optic atrophy because of uncontrolled glaucoma. They require multiple surgeries also. So that part, apart from inflammation, I think glaucoma part has also been looked after in patients with inflammatory TAS.
I would like to bring in James and Dr. Rahul. See this spectrum of PBK. Do you see that in your population, and what do you see? How bad is the PBK there?
Can you hear me? Yes?
Yes, you're clear now, James.
I changed my shirt, so I think that was good luck. And I feel like, you know how our parents always call us for technical support? Now I feel like I'm my mom calling me for technical support. Anyway, in the United States, there's no question that the pathology is not as severe as in India. Every time I go over there to see the cases that you all do DMAC on, it's quite humbling. Most all our cases are Fuchs, and most of them can be pretty straightforward DMACs. And so covering the edema over time, the only things I would add, those talks were fantastic by Vikas, Rahul, and Praveen. For PBK, for novice surgeons, for new surgeons, trying to decide between DMAC and DSEK, you can do that SK the day before surgery to get a better view of the anatomy. Anterior chamber OCT to look for PAS and retrocorneal membranes are helpful. And if you have any question, go ahead and do DSEK if you're more comfortable with that. And then as you get better, you can move to DMAC. And I'll turn it over to Rahul.
With that, we'll go on to Dr. Rajesh Sok. He would be finally, after discussing the various, the anatomy of the cornea, how does the physiology of the cornea work to maintain itself into a state of compactness, and how does the corneal edema progress. Going on to the relationship to the DSAEK membrane by Dr. Praveen, we went ahead to study about the Fuchs endothelial dystrophies presentations, the various scenarios of PBK by Dr. Vikas and Dr. Praveen. Dr. Sunita guiding us about the specular microscopy. We would finally go on to Dr. Rajesh Sok, who would be giving us the pearls of when to replace endothelium in endothelial keratoplasty. Over to you, Dr. Rajesh.
Thank you, Nidhi. Am I audible? You can see my screen?
Absolutely clear and
okay. So I think both Rahul, Vikas, and Praveen, most of the speakers have covered most of the points that I want to touch upon in this presentation. And some of the other points will be covered by the subsequent speakers as well. So basically, when you see a patient with endothelial dysfunction, the patient comes to you with fluctuating vision, glare, reduced vision, discomfort, foreign body sensation, or recurrent painful episodes. So he's looking for relief from the painful symptoms and improvement in his vision. And in terms of the indications, yes, the two main indications we see in our clinical practice are definitely Fuchs dystrophy and pseudophakic bullous keratopathy. And when we analyzed our data on endothelial keratoplasty, specifically for DMEK, we found that almost 67% was pseudophakic bullous keratopathy, where Fuchs was only about 20%. The data from LVP shows a little higher percentage. So the objective of replacing the endothelium is, again, like I said, to improve vision and to relieve the patient's symptoms. Earlier, we used to do full thickness penetrating keratoplasty, and over the past 2 decades, we have moved on to doing selective replacement of endothelial cells. When you see Fuchs dystrophy clinically, you see increased pachymetry and presence of posterior corneal folds, the extent of corneal guttata, the decreased quality of vision, especially while driving at night with mid-dilated pupils, early morning blurring of vision, fluctuating vision, starburst, rainbow while looking at bright lights, clinically seeing microcystic edema, and if there is coexisting cataract, that also changes your management plan. Pachymetry is not a very exact number that you can assign. If you look at population-based data, this was a recent paper published using the tomography, and in the population-based study, they found the mean thickness was about 550 microns, but it can range anywhere from 470 going all the way to 616 microns. And similarly, when we did a study for Indian eyes back in 2000, we also found that the mean central corneal pachymetry was in the range of about 530 microns, although the range was again from 438 to 644. So if we use a particular cutoff value and you have a patient who has a thinner or a thicker cornea, that cutoff value may prove meaningless for that case. So in this flowchart that we have, you can have the Fuchs patient who's symptomatic, either with a clear lens or a cataract. If you have a clear lens and you have the guttae which are located in the central part of the cornea, and you can get adequate peripheral cell counts, maybe you can consider doing a DESCEMET stripping only or DESCEMET stripping without endothelial keratoplasty. Wait for 3 to 4 months for it to clear, and if it doesn't clear, you can move on to doing a DMEK. But if there is extensive guttae going all the way to the periphery, not able to get peripheral counts, or the pachymetry is more than 650 microns, and especially if they have a shallow anterior chamber, the anterior chamber is deep enough for a subsequent cataract surgery, then you can consider a DMEK alone, because the lens is clear rather than sacrificing it. On the other hand, if there is evidence of lens changes, you can look at the endothelial cell count and the central pachymetry, and then decide whether you would want to do a DMEK alone. If you're doing a DMEK alone later on for a subsequent cataract surgery, you always go in for a hydrophobic IOL and aim for a 0.75 refractive error. Combined surgeries have shown better outcomes to stage surgery for patients with advanced cataract and endothelial changes. Whereas now for younger patients where the lens is not showing significant changes and the patient desires to have a premium lens at a later date, either a multifocal or a toric, maybe doing a DMEK first and a cataract surgery later seems to give better results than a combined surgery. In terms of pseudophakic bullous keratopathy, both Vikas and Praveen mentioned that it's important we rule out pre-existing endothelial abnormality. So for that, you look at the fellow eye. You can have intraoperative trauma to the endothelium, either directly from the surgery or the medications that you instill inside the eye. You can have physical damage to the DESCEMET membrane, either in the form of a DESCEMET tear or detachment. You can have post-operative inflammation, either the TAS or the recurrence of endotheliitis, which can result in corneal edema, or you can have progressive trauma from retained nuclear fragments, malpositioned IOL, and vitreous in the anterior chamber, which is touching the endothelium. And these are different in pseudophakic bullous keratopathy as discussed earlier. So when you see early so basically for me, if I see it within the first 2 weeks after cataract surgery, I usually tend to term it as early pseudophakic bullous keratopathy. Always, when you see your patient in the clinic, examine the fellow eye. If the fellow eye is abnormal with a lot of guttae changes, then you need not wait too long for this eye, because you know that the endothelium is abnormal. So you can obviously go ahead and plan an early endothelial keratoplasty. But if the fellow eye is completely normal, then there are two things. One is you look for evidence of any surgical trauma. If there is evidence of conflict, you can talk to the primary surgeon if it's a hard cataract or a non-dilating pupil or prolonged surgery, then you can understand that there may have been surgical trauma damage to the endothelium. You can wait at least for 8 to 12 weeks, give medical therapy, hyperosmotics, topical steroids, control the IOP. And if it doesn't show any progressive change, so you keep doing serial pachymetry, either OCT based or do ultrasonic pachymetry. If it doesn't show any improvement over the 8 to 12 weeks period, then you can plan and evaluate endothelial keratoplasty. If there is no surgical trauma, then you go ahead and do an anterior segment OCT. There are two things. Either you will find that there is some element of damage to the DESCEMET, resulting in a DESCEMET detachment, which can be managed by decimetopexy using air or gas. If there is no DESCEMET detachment, but you still have edema, then it's most likely that this is some insult to the endothelium from medication toxicity. If there is inflammation in the eye with a lot of pigment dispersion, dilated pupil, raised IOP, then you can think about toxic anterior segment syndrome. Sometimes the patients can come with initial clear cornea for the first few days after surgery, and then a week later they suddenly have inflammation. So that could be a recurrence of viral endothelitis, something that the patient had in the past, and without any antiviral cover post-operative with the steroid, you have a recurrence of the viral endothelitis. And the third thing could be the inflammation could be because of frank endophthalmitis, which is resulting in endothelial dysfunction, and which can also result in corneal edema. But there would be other signs of endophthalmitis which will give you a clue as to why you have the corneal edema. In terms of late, if you see maybe more than 2 weeks later, again, look at the same protocol. Always examine the fellow eye. If the fellow eye is normal, then this eye is most likely a mechanical damage. If it is edema is located to the inferior half of the cornea, then suspect that there may be nuclear fragments within the AC, which is resulting in the corneal edema. If it's a malpositioned IOL, especially IOL anterior chamber, either angle or iris supported IOL, it could be something related to the IOL, or carefully look for any vitreous that's there. So there could be a posterior capsular defect with vitreous coming into the anterior chamber. So that can be looked at if you look at the configuration of the pupil, you can see peaking of the pupil, and sometimes the vitreous is touching the endothelium. You can have the focal corneal edema. Again, an inflammatory damage would be either endotheliitis or endophthalmitis. If it is abnormal, it's a decompensating endothelium from a pre-existing low cell count, and then you have to plan for early endothelial keratoplasty. So this is a patient with post-operative TAS. As Praveen rightly pointed out, you see increased fibrosis at the site of the incision, both at the main and the side ports. You see that the pupil is kind of mid-dilated. You see areas of iris atrophy, as Dr. Titial mentioned. There's a lot of pigment dispersion. So that is one of the points of differentiating between endotheliitis and TAS, in the sense that in TAS, you will see a diffuse dusting of the endothelium with the pigment, whereas with endotheliitis, sometimes you will see the keratic precipitates either mostly in the inferior half or localized to a certain area, either in a linear or a circular pattern. And I have found that in edematous cornea, if you have to look at the keratic precipitates, use an infrared. So either on your refractometer or on your OCT, if you have the infrared image, in the infrared image, you can very clearly see through the edema, and you can see those keratic precipitates, which can again guide you as to what this may be. And for that, you may consider taking aqueous samples, sending it for PCR, and then decide what kind of medications you may want to give to your patient. Otherwise, even after doing a successful endothelial keratoplasty, you may have an early failure of your graft due to the recurrence of the endotheliitis. So this is a patient you can see at 1 month follow-up itself. The eye is looking good. The iris was very floppy in this case. That is the other thing that happens in TAS, is the iris loses its normal texture. So I had to do a little bit of pupilloplasty to ensure that the iris, the air does not go behind the iris. And at 3 years follow-up, the eye is maintained clear. The cell counts at 3 years is about 1,237, which is slightly on the lower side, but again, still the cornea is well maintained with lower risk of rejection. I think he'll do well in the long run. So this is a patient, again, referred from one of my colleagues who was doing a cataract surgery, and at some step of the cataract surgery, before he could complete, he was planning for a capsular excess. But before that only, he saw that he had injected viscoelastic into the plane and resulted in a complete DM detachment. So this is how it was sent to me for an endothelial keratoplasty. So we did anterior segment OCT, we looked at it, and we decided to do a decimetopexy, which I had to do twice, because after the initial decimetopexy, it was partially attached, but still more than 50% was detached. And so after the second decimetopexy, the cornea cleared up, and after waiting for a month, we were able to go back and do a repeat cataract surgery using a fresh corneal incision away from the original site and taking precautions that we do not have a DM detachment. Aphakic bullous keratopathy, again, always examine the fellow eye status to look for any abnormality in the endothelium. Also look at the refractive status of the fellow eye. You will need a secondary IOL implantation, which depending on the experience of the surgeon, it can be done either as a stage surgery or it can be combined with the endothelial keratoplasty as well. And often these eyes, because of complicated primary surgery, the pupil is kind of dilated. There are peripheral synechia, so that needs to be addressed. You may require to do a pupilloplasty as well, along with the secondary IOL implantation, especially if you are planning DMEK, because you don't want your donor tissue to go into the posterior segment. And often the aphakic bullous keratopathy, because of the peripheral synechia and sometimes the vitreous in the anterior chamber, can have raised intraocular pressure. So it's important that you control the IOP, because if you have a patient who's on maximum anti-glaucoma medication and you take the patient up for endothelial keratoplasty with the usage of steroids post-operatively, you may still get uncontrolled IOP, which cannot be managed. So I think it's important that we always control the intraocular pressure before either by doing anti-glaucoma surgery and then only take the patient up for an endothelial keratoplasty. So this is the same patient who had the aphakic bullous keratopathy. So here we did the secondary IOL implantation using the Hoffman pocket along with 90-prolene sutures, and we did a DSAEK with that. And you can see day 2 post-op itself, the cornea is looking clear because we debrided all the edematous epithelium. The vascularization, what you see was basically superficial vascularization, which came off. There were few deep vessels which did disappear after usage of steroids, and finally ended up with 20/30 vision with a little bit of myopic error, because in these cases, when I plan for the IOL, I always want to leave the patient a little myopic because it helps them with their near vision. I wouldn't want to have a patient with a hyperopic postoperative refractive outcome. Failed graft, again, it's important. You may look at a failed graft and be tempted to straight away jump in and do an endothelial keratoplasty, which you can definitely successfully perform. But it's important to look in the history and see what was the recovery when the graft was cleared. Often you have corneal grafts where the patient records of the patient history clearly specifies that despite having a clear graft, he did not have any useful vision because of very high irregular astigmatism. In such a case, if you do an endothelial keratoplasty, you may achieve a clear graft, but the patient may not have any, useful vision post-operatively. So sometimes in such cases, we can repeat a penetrating keratoplasty to try and achieve a better refractive outcome. Also, the etiology of graft failure, if he has had a multiple rejection episode, or you look at his record, so then you have to be prepared for the post-operative management following the endothelial keratoplasty. Also, look at the intraocular pressure, because a lot of grafts fail because of uncontrolled intraocular pressure as well. So it's important that you pay attention to controlling the intraocular pressure. Anterior segment OCT is very vital. Look at the posterior curvature. Sometimes the graft can be very flat, or sometimes depending on the original graft-host disparity, you can have a steeper graft as well, because this has some impact on the apposition of the graft in the immediate postoperative period. The posterior graft-host junction also should be assessed. Look at the stromal characteristics, because if the anterior stroma shows significant amount of scarring, then despite doing a good endothelial keratoplasty, you may not achieve a great visual outcome. Look at the configuration of the anterior chamber, both in the center and periphery. In terms of surgical techniques, my preference is either doing a DMAC or an ultra-thin DSEK. And the size of the graft can be the same as the original graft, or sometimes it can be 0.5 millimeters smaller, so that none of the, especially if you have a posterior graft-host junction that's kind of protruding into the anterior chamber, so you don't want any edge of the graft being lifted up with that posterior abnormality. So this is a patient who had an anterior chamber lens. DSEK was done, and within a year the graft failed, and this is how patient presented to us. So we decided to remove the AC IOL, do a Yamane technique of scleral fixation of IOL, and then we combined it using doing a DMAC. And you can see even at day 5 post-operative, the cornea looks pretty clear, and the patient was able to see 20/40 at day 4. Rarer conditions like congenital hereditary endothelial dystrophy, definitely not for the beginning surgeon. Here, the patient can present with diffuse corneal haze or opacity starting from birth. They definitely have a risk of amblyopia with photophobia and nystagmus. Surgical intervention, both penetrating keratoplasty and DSAEK, have been reported in literature. We have 2 publications in cornea, which are in press, looking at our outcomes and the role of anterior segment OCT in planning DMEK surgery in congenital hereditary endothelial dystrophy. And another finding of corneal folds after doing successful DMEK. You find folds in the anterior cornea. And as what Praveen was explaining to us about the corneal stromal characteristics, the other point that you have is the uneven distribution of the glycosaminoglycans. You have more of the dermatan sulfate in the anterior cornea and more of keratin sulfate in the posterior cornea. The keratin sulfate has greater ability to absorb water, so it can keep the water, it can retain the water for a longer period of time. So that's why the posterior cornea swells more. So in CHED, the proposed hypothesis was that if you do an DMEK, the first edema to go away is from the posterior cornea, and the anterior cornea being more rigid is not able to conform to the change in shape, and then it gets thrown into these folds, which look like pretty much like the reticular folds that you see in high myopes. When you do a LASIK, you see those cracked mud appearance. The surgery is easier to perform beyond 2 years of age. What we found. If you do it in younger pediatric eyes, because of the tendency, more elastic nature of the eye, the surgery can be very difficult. And there have been reports where people have attempted surgery in younger patients, and they have had to abandon DMEK and go on to doing a DSAEK. So a DSAEK is a good choice of surgery, and comparatively, there is a paper from LV Prasad where they have compared non-stripping DSAEK versus DM stripping DSAEK, and they found the outcome is similar. And especially in younger eyes, it's sometimes very difficult to strip the DESCEMET because the DESCEMET is very tightly adherent. So the paper that we published, it's in press in cornea, looks at a preoperative anterior segment OCT assessment of the cornea. What we found that up to age of below the 10 years, you don't see thickening of the DESCEMET membrane significantly. So in those cases, you can safely do a non-DESCEMET stripping DMEK and you can have good outcomes. However, above the age of 10, we find that the DESCEMET membrane is quite thickened.
In those cases, it's easier to remove the DESCEMET membrane during surgery. So this is a 8-year-old male with CHED and underwent DMEK, and post-operatively you can see the visual acuity has improved from 624 to 612, and over a period of 2 years follow-up, he is maintaining good vision. And we did subsequently the surgery in the fellow eye as well. And the change in corneal thickness from 864, you can see, has gone down to about 539 microns. That's the advantage of DMEK also in this situation, is that you don't add any stromal thickness, unlike when you're doing a DSAEK. Iridocorneal endothelial syndrome, it's again a rare condition, but has a very high incidence of secondary glaucoma, especially in the later stage of disease. Clinically, you can recognize it from the distorted pupil and the peripheral anterior synechiae. What we have found in our practice is that early endothelial keratoplasty, you can replace the abnormal endothelium with healthy donor cells, and thereby you can reduce the severity of the disease by slowing down the progression. And often, if you have a shallow anterior chamber, you can combine it with cataract surgery to improve the anterior chamber depth. So this is a patient referred with ICE syndrome where a cataract surgery has already been performed, and you can see that there is corneal decompensation. So here the pressure was raised, so we had to first get the patient's IOP under control by doing a Ahmed glaucoma valve where the tube was placed in the pars plana, and after that we followed it up with a DMEK surgery, and he's doing well after that. This is again a younger patient, 40-year-old male who presented with unilateral corneal edema and the peak pupil inferiorly with the peripheral synechiae and absence of any keratic precipitates. We were able to pin down the diagnosis as eye syndrome, with the other eye being completely normal. We just performed a phakic DMEK, and his visual acuity is improved out to 20/30. He has an early posterior subcapsular cataract, which again, because his vision is still maintained, he's happy with it. We are waiting for it, and over a period of time, we can safely go ahead and do his endothelial cataract surgery in this eye. This is a patient, again, a similar young patient in his 40s when he first came to us. So we decided to do a DSAEK. You can see that the graft size is pretty small. This was just a 7mm graft. And we did a DSAEK in this case. So for 7 years, he was doing very well. Then he developed a cataract. He came to us for a cataract surgery. So we removed the DSAEK graft because the cell count had dropped down to about 450. So we were not very sure that this would withstand the cataract surgery alone. We did the cataract surgery, tried to do a pupilloplasty, and the DMAC did well, but the central pupilloplasty closed down. So we had to go back and do a pupilloplasty, and ever since he has been doing well and maintains 20/20 vision, and the cell count is about 2,418 at 6 months follow-up. This is again the last final case, again what Praveen had shown. So this patient also a film actor from the Middle East. He had gone in for the colored iris implant, both eyes, the one from bright ocular, ended up with uveitis and bilateral corneal decompensation. And he got the iris implant removed prior to coming here. So this was his clinical picture, and he was very demanding because of his profession, and he wanted us to do something very quickly for him. So we went ahead, did a cataract surgery because he was also developing a cataract, anterior subcapsular cataract. So we did a phacoemulsification intraocular lens and DMAC in the first eye, and a week later, because that eye had recovered well, a week later we went ahead and did his fellow eye, and in about 2 weeks, his corrected visual acuity had improved to 20/20. So basically, in conclusion, corneal edema both has visual and physical symptoms. We need to address both. It's important to determine the etiology of the corneal edema and then plan intervention. You cannot just use one surgical procedure for each and every case. And any coexisting problems, especially inflammation and intraocular pressure and any malpositioned IOL or any vitreous in the anterior chamber, all these need to be addressed prior to corneal surgery. If the corneal surgeon is not very familiar with these procedures of secondary IOL implantation, then the case should be referred to somebody who can do a good job, and then you can come back to do a endothelial keratoplasty. And especially in complicated scenario, sometimes it's better to do a staged procedure than to try to do everything at the same time. Thank you for your patient hearing.
Thank you, Dr. Rajesh. I think there is no question on the chat box once you've crystallized the whole of the flowchart so beautifully. We'll go on to Dr. Chatyal. Dr. Chatyal will be talking about the evolution of endothelial keratoplasty over the years. Why and how? Over to you, Dr. Chatyal.
Thank you, Nidhi. I think we had a wonderful talks on how did we reach up to the stage where Rajesh could do surgeries for such a difficult cases. So there has to be a evolution of any surgery, and that holds true for endothelial keratoplasty also. For this presentation, I'd like to acknowledge the help of Dr. Manpreet Kaur. She's working with me as an AP. I think the initial concept of endothelial keratoplasty is basically like people like me who came through early stages of full thickness graft and anterior lamellar keratoplasty. We had no concept of going through a posterior route in these cases. We always thought about having an exact fit of a tissue which we're going to replace, which should have a perfect anterior and posterior smooth surface. In that regard, I think the initial surgery would have been the historically posterior lamellar keratoplasty through anterior approach. Then now we have a posterior approach, which we call a modern day EK surgeries, and future would be a no keratoplasty. I hope this comes out in these cases. Let's see how this entire endothelial keratoplasty evolved in last almost 60 years or so. The first description of posterior lamellar keratoplasty for endothelial disease was described by Tillett et al. In 1956, published in AGO at that time. And he had done a large incision, which is almost 180 degree in the host cornea, then did a stromal dissection through this 180 degree incision and removed the entire button, which involves a posterior stroma as well as endothelium, then implanted the donor tissue through this large incision and subsequently sutured it. So this was later modified by Baraker in 1960s. You all know he was pioneer in microkeratome surgeries. So he did a hinge flap surgery in these cases and posterior definition of stromal endothelial bed and put the lenticule sutured in the stromal area in these cases. So we're looking into these. There have been many other people worked in this regard in late 90s and early 2000 And prominently they were Culverstone, Busin, Arfa, Eller, Silk, and Dimitri Ajar. They describe these techniques in a different manner. If you look into John Dart and Culverstone, they describe this as endothelial laminar keratoplasty, and subsequently Busin described this as endokeratoplasty. They all worked through the anterior approach, and Dimitri Ajar also worked with the keratome flap assisted posterior keratoplasty. He referred in a JCRS publication. So these are various people worked in this regard to improve the endothelial disease and trying to maintain the anterior cap in these cases. But you see, there was a definite need of a shift from anterior to posterior laminar keratoplasty, because these anterior approach did not really give a good outcome in terms of they require a larger corneal incision, a larger corneal flap, and a lot of suture-related complication to attach this donor lenticule into the existing host stroma. And they also had a significant angular curvature glaucoma because of synechia formation. There was a large endothelial damage that subsequently led into failure of these grafts. And ultimately, what we would have thought about getting a good posterior apposition in a stromal bed, they had a very poor apposition of a graft in these cases. Therefore, there was a definite need of innovation, evolution of a newer modern day endothelial keratoplasty. That was basically as posterior laminar keratoplasty described of Mellis in 1998, subsequently by Mark Terry as a DLEC. Then we had in 2004, we had a DSAEK surgeries. Subsequently, Price made more popular procedure. Then we had automated surgery in 2006, and now we have DMEC described by Mellis in 2008 and PTEC in 2014. I was getting through the article published by Mellis. What would have been a thought to getting into the posterior part? There were 5 important things which made him to do a posterior root surgeries. He had seen DMD cases in a cataract patient getting attached to the air injection. Then he did an experimental study to see if the endothelial lenticule can be attached. In these cases, that would be anti-gravity surgery without suture. And he realized there's a negative inhibition pressure, as we described the endothelial function in the beginning of this session, would also work out in a opposition of lenticule in these cases. And the stromal surface of donor as well as host will have a much better stickiness of a transplant tissue in these cases. And he was the first person to realize the air bubble can effectively work in attaching these lenticule in these anti-gravity way in these cases. And he came with the new technique of PLK in 1998, where he described the air bubble tamponade of a graft in these cases without suture. So this was one of the first surgery of without suture endothelial keratoplasty. And the Mellis technique, the donor preparation, was almost similar to what we do nowadays for a routine manual dissection with these cases as such. You see this technique described, donor full globe was taken because artificial chamber was not used. He did a 60% dissection into the stroma, and that then after a dissection, he put a plastic sheet there and then cut the corneoscleral rim on a Teflon block. He punched 7.5 to 8 millimeter. Then subsequently removed the plastic sheet with the remaining anterior stromal thing. And this was a donor preparation. A host preparation also, he had to do a larger incision, which was almost 7 to 7.5 millimeter. Then there's a scleral tunnel at 60% depth, 80 to 60% depth in these cases. Then remove the posterior lamella, which had a stroma and disease endothelium by a punch. Subsequently implanted the lenticule with air bubble placement in these cases, and the host was suture. There was a concept which later Mark Terry in 2000 described his technique as a DLEC in these cases. That is a deep anterior lamellar, posterior lamellar keratoplasty in these cases. So he had described many instrumentation. Very interestingly, these are still being used for a dissection. The curved dissector, Devers and Terry dissector, used for lamellar dissector. He had a specific punch, Terry's punch made for a posterior punching of these cases. Later, he described this long Cindy scissor, right and left hand, to cut this posterior dissected piece of stroma and endothelium. And this was the Olse insertion spatula, where the surface will be coated with the viscoelastic and graft is to be endothelial side on to insert inside. Later, he did describe the smaller incision surgery where the donor lenticule could be folded and inserted inside. And that was the technique to describe the smaller incision, because larger incision induced much more difficulty in managing astigmatism of these patients. So this was a technique which did have a rapid visual recovery as compared to the full thickness surgery in these cases. They did have a graft clarity also. But the vision was not perfect in these cases, and it was a very difficult procedure as such, not easy to replicate by other surgeons. I remember we also procured these instruments and could not replicate the procedure in our place also. This led to exploration of alternative procedures for endothelial keratoplasty. And Mellis in 2004 described a simplified method where he totally eliminated the lamellar dissection of recipient stroma, which was a major difficult part in these cases, and only described the DESCEMET in these cases where DESCEMET endothelial complex was taken away and placed the donor lenticule as described by him. And initially, he described this under the injected air bubble in antechamber to have a better visibility of DESCEMET during scoring. Or sometimes he did put a reflectile glide inside, which also would give you a better initiation and better completion of a descemetorexis. And sometimes you could use the forceps on these cases and did a 9mm mark anteriorly and subsequently scored from behind. But this surgery was ultimately made more popular by Francis Price group, and they described various techniques in these cases. And he compared MICROKERATOME dissected lenticule later, but it was Grosbois et al. Who described this earlier. This technique was described in 2006. So this was a study by Francis Price where he compared MICROKERATOME versus the manual dissection. And he concluded that MICROKERATOME dissected tissues are better in terms of attachment, and the visual quality is also better, and recovery was faster in these cases. But in DSAEK and automated DSAEK also, there was a challenge of graft dislocation. We all face this. Many more patients require multiple sessions after surgery, pupillary block, glaucoma, and graft failure. And we all looked into how to modify these procedures to decrease complication in these cases in this regard. In this way, to have a better attachment, in between 2008, Mark Terry had advocated a peripheral scraping of the stroma just beyond the 6mm optical zone. And this he thought would increase the adherence of graft in these cases and decrease the chances of post-op dislocation. Then he also described a Cindy sweeper he could use anteriorly after injecting air pressure. Anterior sweeper will decrease the chances of dislocation post-op period. Meisler et al. Described the anterior antechamber air fluid infusion or exchange in these cases. Grosbois had the idea of a total air fill for at least 1 hour of surgery, then subsequently dewurfing in a slit lamp. Price et al. Talked about fenestrations, stab incision interstroma, which was quite popular in the beginning. And he described if you have combination of venting incision and the air pressure and massage, the chances of post-op dislocation from a 50% would decrease to 6%, which was successful procedure assessed. We also had IOCT visibility of these cases. We also tried to compare how effectively we can assess the lenticular apposition in a DSAEK surgery. And we realized if you do a combined procedure of anterior massage and continuous antechamber pressure with air, also decreases the time. In a primary surgery of DSAEK, we could see within a 1 to 3 minutes of manipulation, bimanual manipulation, the graft was well attached. So this understanding will decrease the pressurized eye for a longer period in these cases. So this is what we could see in these cases. The majority of time, post-op pupillary block was a major concern. People would remove the air bubble to a smaller size, do a peripheral iridectomy like we do for DMEC surgeries. Some people use a mydriatic cycloplegic things. A similar technique we also described to decrease the problems. But change happened in terms of getting a good dissection of donor lenticule and DSAEK surgeries. MICROKERATOME femtosecond were used to get a thin lenticule in these cases. Apart from talking about ultra-thin DSAEK, which is a very popular method, now people talk about nano-thin DSAEK lenticle, which is less than 50 microns. Maybe this will have a better visual outcome as compared to DMEK, or be equal to DMEK also. There are various nomograms to do. I think Parveen did talk about assessment of a femtosecond laser tissue. We also published our results where we compared the endothelial damage with the electron microscopy studies, and we did a atomic force microscopy to see, and it is correct that microkeratome are much better than a femtosecond laser of today's generation to prepare lenticule in these cases. Insertion wise, we had spatula to begin with, then came forceps to decrease the size further. Then you have glides, and you have injectors, inserters, and these all were made changes to decrease the damage which can happen during manipulation or injection of these lenticules. And Mark Terry did describe larger the incision, better is the retention of endothelium. Tighter holding of a tissue also will have more damage in these cases. IOCT or have a better visibility, gives a better analysis of what is happening inside in these cases. Then let me talk about how DMEK came into practice, because DSAEK would not give enough quality of vision which we talk about as compared to the physiological surgery with DMEK in these cases. And it was the peeling techniques I described initially with the direct peel method. We still do a direct peel method, or you have a big bubble method by creating the big bubble like you do for cases where DALK, and subsequently punch it from endothelial side. So you have a manual peeling technique of Maillage and Lee, then scuba technique, which Price had described earlier. But we have all gone into this, and we know that direct peeling techniques, manual peeling techniques are better in these cases. The endothelial cell loss is quite less, 4 to 7% with the manual peeling technique as such. So peeling techniques has been now, I think we can standardize them in a better manner and get a better endothelial cell count in these cases. Pneumatic dissection, now it is basically limited to cases with PDEC, which has been made popular by various people attached to Agarwal group. Then in between, we had a hybrid technique because unfolding or DMEK tissue was difficult. So you did have a little bit of stromal tissue in the periphery so that you could do a better unfolding in these cases. PDEC, as talked about Praveen, we know that younger donors can be taken up in these cases. And this, I think, is still in a modifying phase where you use a glass pipette or IOL injectors to insert the roll inside. And opening the roll, various techniques have been described to make it simpler and better, where you have different types of folds inside. Accordingly, you have to design how you're going to improve these. So it is better to have orientation seen in through the microscope or through other resources. See the correct orientation, which is like this for your cases, and unfold them better. So there are stampings, or you can have various other signs which can be give you a better orientation. Like this one, you can see the cannula giving a blue reflection. That means you have a better right orientation of graft. OCT will also give you a better understanding what type of role you have and what technique you have to do it in these cases. As various videos are shown by Parveen and Dr. Fogla, now we can do a EK in all types of surgeries where endothelial dysfunction has occurred, and that's because we have evolved from the early stage to a modern surgery in these cases. I think this will be covered by the coming speakers. The future will be a no keratoplasty or DVEC, which may be a good indication for early cases of Fuchs as such. Rho kinase inhibitors or endothelial cell transplants, culture endothelial cell transplant may be a future of surgery in EK. To summarize, I think we did have anterior approach because that time we didn't have a concept of posterior approach. We never thought lenticule can be attached without the suturing in these cases. Then came the idea of putting a thin lenticule from posterior side with a small incision, sutureless, and people still do this, one of the commonest surgeries. Now a DMEK, which is just replacement of endothelial DESCEMET complex with healthy donors. would remain for a longer period. Any surgery which can be replicated by various surgeons would be a suitable surgery for patient, for surgeon as such. So I would thank you for listening for this talk. If you have a correct orientation of a surgical aspects or disease, you definitely have the right perspective of what has happened in the future and what has happened in the past and what is going to be future of endothelial keratoplasty. Thank you for your kind listening.
Thank you, Dr. Titial. That was absolutely the whole journey we have taken with you of endothelial keratoplasty. We'll quickly go on to Dr. Roboto's talk. I think it's a much awaited talk. Dr. Roboto, welcome to Eklg, and we would be, a lot of people are waiting for a talk on DSAEK.
Thank you very much, Dr. Neti. It's a pleasure to be part of this illustrious group of speakers today. A few of the speakers have already mentioned this, including Dr. TTL and Dr. Sunita, but I'm going to talk a little bit about use of DESCEMET stripping without endothelial keratoplasty, or DSO, as an alternative for endothelial keratoplasty for Fuchs endothelial corneal dystrophy. These are, let's see. So my slides are not advancing. Oh, there we go. They're just some of my affiliations which are not relevant here. So we've reviewed a little bit extensively about Fuchs endothelial dystrophy, knowing that the guttata effectively occur in the center of the cornea and then decrease as we go from the center to the periphery. And you can see that there in this nice images below. And Dr. TTL just gave a very nice overview of endothelial keratoplasty for Fuchs endothelial corneal dystrophy, which has changed over the past 2 decades now, with DMEK being the kind of principal treatment for Fuchs endothelial corneal dystrophy and routine cases. So about 10 years ago, there were some publications that came out regarding spontaneous remodeling of corneal endothelial cells after DESCEMET stripping. And some of these occurred with DESCEMET attachments after cataract surgery with spontaneous clearing, cases where there was loss of DMEK grafts with clearing of the cornea, or graft free rolls. And this is one of some of the earlier studies from 2010 and 2012 that describe these events. So DWEC, you've heard, stands for descemetorrhexis without endothelial keratoplasty, or DSO is the other common reference for DESCEMET stripping only. This is really what we're talking about now as a form of regenerative medicine. And as we all know, regenerative medicine is a very hot topic in medicine today. Interestingly, this technique was described back in 1955. Dr. Pufiki, who is a French ophthalmologist, actually wrote about this in Roycroft's book of corneal grafts. And he has 2 paragraphs in his chapter on lamellar keratoplasty on this, describing removing DESCEMET's membrane with the guttata and describing clearing. Now, but in his cases, the clearing failed after a short period, and he went on to say that they needed corneal transplantation. But he actually noted this nearly now 65 years ago. I'm actually doing some research trying to figure out what to find there are no references for this from the book, but I am trying to research this topic. The big advantage of DWEC is that you're not, unlike all other types of endothelial keratoplasty, we don't have rejection here. These, rejection rates, I don't think they've been mentioned too much, but for DMEK is around 1% to 2%. In some of the publications here, it's 0. Also, these patients do not require long-term steroids, another advantage, not worrying about patient compliance. But as some of the speakers have mentioned, this is really only for cases of Fuchs corneal dystrophy and not for bullous keratopathy. That's a very important take-home message. Naming these procedures is fun, and we wrote a little editorial about that. There's many different ways to describe this, but I think DWEC and DSO are probably what's stuck around. So this is a typical case. This was a 67-year-old woman who was losing vision. This was early on when we started doing this back in 2014. She had had amblyopia in the right eye. You can see best corrected vision was 2200 in that eye. Endothelial cell count, pachymetry was 663. She had kind of about 4 millimeters of non-confluent gutata on the right side, and the periphery looked healthy. And you can see a picture of that right here. We went ahead and did DSAEK stripping only. And you can see at 1 week, as expected, you would see dense corneal edema. You can see that in the OCT below. But by 1 month, the vision started to clear quite significantly. You can see vision improved to 21/25, and you can see the OCT below. And then by 2 months, her vision was 20/70. Remember, this is the eye with amblyopia. She's already better than her pre-op vision of 2200, and you can pick up endothelial cells by specular microscopy. And this is kind of a typical course for these patients. Here, the patient 3 years later, her vision has improved to 20/60 plus. Remember, this is the amblyopic eye with cell counts of about 1279. And then in the left eye, which she proceeded to have several later, was 20/20, and again, cell counts around 1200. And I think these are typical cell counts that we often see after the DWEC procedure. And I'd be interested to hear from our other colleagues here what their experience is. So here, again, you can see the DWEC procedure. You need to have healthy peripheral endothelial cells. We heard about how important that is. And we usually offset our NIDAC pachymeter. It also gives us peripheral measurements, or use confocal microscopy if that's available to you to look at peripheral cell counts. But you can see here, in this case, just 1 month after DWEC procedure, we can measure cell counts of almost 800 cells per millimeter squared with the DWEC procedure. So great idea, but what is the problem with the DWEC concept? The problem with the DWEC concept is that although there is the potential to heal after the DSAEK membrane is removed, it's highly variable between patients. Now, this really speaks to the regenerative ability of the endothelium and identifying patients who are potentially going to be good candidates for this procedure. Now, the paper by Boker and Kathy Colby, published in 2016, really looked at 4 different DWEC groups. And basically, we're able to break it down into what I think are 4 practical groups. Those were the fast responders, those people who really showed improvement in less than a month after surgery. The responders, which were more in the 1 to 2 month group, those slow responders that took up to 3 months to respond, and then the kind of non-responders, which were more than 3 months out after surgery. So this is an important concept to keep in mind when you're considering this procedure. There's also obviously factors that are involved in cell regrowth or cell migration. Obviously, historically, we're taught that cells do not have much mitotic potential, and that cell migration is the principal way by which the endothelium covers up its denuded areas. But really, proliferation is another area where we are starting to understand that there may be more proliferative potential than potentially thought. And obviously, there's cell-guta interaction. My colleague from Mass Eye and Ear Infirmary, Kunis, has shown the toxicity of gutata to surrounding endothelial cells and apoptosis. Obviously, the environment in which the endothelial sit is also important. If patients have additional either inflammatory issues or glaucoma issues, these may affect the ability of the endothelium to migrate or proliferate. So, so this concept of migration or proliferation is an important one. On confocal microscopy, we've been able to demonstrate bilobe nuclei hyperchromatic nuclei, as well as segmenting cytoplasm, which is all indicative of mitotic activity of the corneal endothelium. But we also have noted there is a decrease in endothelial cell count with this procedure in the periphery. Signaling cell migration is probably the principal mechanism for replacement of the central endothelium. It's also important to know that in the past, these procedures were done with larger stripping techniques in the range of 6 or 8 millimeters. And there's definitely a limitation to how quickly these cells can cover up these areas that have been stripped, and part of the reason for the smaller strips that we do now. I just wanted to walk through some of the surgical steps here of the DWEC procedure. We want to first mark the area to perform the descemetorrhexis. I mentioned before, the area that we're typically doing is around maybe 4 to 5 millimeters. This is important if you have a large or eccentric pupil to make note of that. You don't want this area to be eccentric to the entry pupil. So this is, you know, again, you can use any marker you like. I like this little hatch marker that I developed, which is about 4 millimeters. And again, most of the studies have looked at showing that around this 4 to 5 millimeter stripping zone is the best area to remove the gutata, and also kind of defines the parameters which we want to use to remove or select patients for the DWEC procedure. And next, depending on the incisions, these are usually done for us mostly in combination with cataract surgery. So we're doing the standard phaco incision, and just at the end, before we remove the viscoelastic after the IOL has been implanted, we go ahead and strip the area. I'll show some videos of that in just a minute. But many times we have younger patients whose lenses are clear. We're doing a phakic DWEC, and obviously all you can do, if you have a micro forceps and a reverse Sinski, you can go ahead and just make a small paracentesis and perform the procedure through that. Again, we like to use viscoelastics. It's much easier to do the stripping, especially in phakic patients. And if we're doing a small incision, we want to use a cohesive that comes out easily at the end of the surgery. So one of the tricks here is initiating the tear for the Descemet's membrane. Because it's so small, Dr. Praveen mentioned the importance of not scraping the underlying stroma as it induces scarring. And this is very critical for the DWEC procedure. So getting initiating the start can actually be a bit challenging because you have to break through Descemet's without really damaging the stroma. And we do that usually with a reverse Sinski or microforceps with a tooth. If you can use a disposable like 25 gauge retinal forceps if that's available to you, or again the reverse Sinski to start the scoring method. This is a little device with a micro forceps with a tooth on it, a 50 micron tooth that allows us to start the score without potentially penetrating into the stroma too much to start the healing process for the procedure. Now it's important to strip as opposed to peel or peel as opposed to score. And scoring we're used to doing with DSEK and DMEK, but here that scoring really violates the corneal stroma and will result in scarring. So this peeling or stripping, and that's why descemetorrhexis is used, stripping or peeling is used as opposed to the scoring method. And it's important to note that unlike a capsulorhexis, the Descemet's actually is much easier, it's much more fragile, breaks more easily, and you have to end up re-grabbing it several times or switching direction to complete the tear, and you'll see that in the video. So this is just another forceps that I helped develop with a little tip, removing that. But we actually showed in a paper a few years ago that the importance of stripping or peeling over scoring. And in this paper, we had 17 eyes of patients. And I always peeled or stripped. My colleague scored and then switched to stripping. And really the failure rate for those patients that were scored versus stripping was much higher from the scored patients compared to the strip patients. So this concept, again, is very important. So again, just some highlights from the surgical technique. We want to limit the size of the descemetal rexus to about 4 to 4.5 millimeters. We want to make sure it's well centered, that there's no tags or scarring centrally for good vision for the patients to strip or peel and not score, and to avoid any stromal damage. So this is just, using the reverse Sinskey here. Hopefully that's running at appropriate speed. Dr. Nettie said it was a little slow, but again, trying to break that is not so easy. Remember, in Fuchs, the decimase is thicker, but once you're through it, it's pretty easy. This is just using a pair of Utrata forceps. This was early on. I'm showing this because we don't always have access to everything that we need, but you can do this with a pair of Utrata forceps. They do make a pair of reverse Utrata forceps. I think if you have access to that, that would be ideal if you don't have access to microforceps. But again, here I marked, but I didn't mark with my modern way. This is from several years ago before we had some of these other instruments. Sometimes it can be challenging to grab the decimase, and you have to kind of restart it again. Again, just using reverse Sinskey just to get that initial tear. Sometimes we also reverse direction if we can't get it, but I'm showing this kind of not in a sped up way, but in a kind of real way, so you can appreciate how long. It doesn't really take that long, but once you get it, it's very good, and then you're essentially all done. So this is another technique here, using the marker and the microforceps. And I would encourage you, if you're doing this in the beginning, to make sure it's well marked. Again, this is after cataract surgery, and this has the little microforceps with the tooth on it. Again, it's a little easier with microforceps to grab the decimase. Sorry, it's just a little off center here. I think we'll recenter in a second. But oftentimes we'll switch direction if we cannot go all the way around to finish it. And again, it's very important not to leave any tags. Now, around 5 or 6 o'clock, there's actually a little tag where it's incomplete. If you leave that there, it's going to scar. So we always make sure we try to remove that tissue and complete the rexus so it's not lifted off, as you see right here. So obviously a DWEC surgery does have its complications. Obviously delayed healing. This is about, from the published literature in kind of the Western and from Australia, the US and such, it's around 20%. So 80% of the people clear, but we have about a 20% failure rate. And trying to identify who's going to be a good candidate for this is important. Decentration of the rexus is very possible. It usually gives people significant photic symptoms. And you can get stromal scarring from chronic edema, as well as from trauma to the underlying stroma. And you can form these posterior stromal nodules from these areas if you don't complete these tags. And Greg Maloney has a nice OCT showing these little nodules that form from these tags. So there is a refractive effect with DWEC, just like there is with DMEC. And we retrospectively looked at 25 eyes from our series and found there was somewhere from a 0.65 to 0.38 hyperopic shift to whatever target we were aiming for, similar to DMEC. So we go ahead and always adjust for about a half a diopter hyperopic shift when doing this as a combined procedure. We also have, as I mentioned before, some patients have DWEC under a phakic situation, and this is one of our patients who actually had DWEC surgery with phakic, and then several years later developed enough of a cataract that required surgery, and we were able to very successfully perform cataract surgery in this patient. In fact, the endothelial cell count went up. It almost doubled from like around 1,200 to over 2,000. We're not sure exactly why that happened, but it was a very impressive jump. And it may just be that the cells are stimulated from the trauma from the cataract surgery, obviously using a low flow setting and taking precautions with the soft shell technique. Postoperative management for DWEC patients, very similar to that for PKP and EK. I mean, we start off with frequent steroids and typical antibiotics. And, we don't have to worry about rebubbling in these patients, which is quite nice, and positioning, which might be an issue. Basically, the post-op is very similar to cataract surgery. Now, the question that's quite different is the use of ROCK inhibitors. And this has been an area that is being intensely investigated at this time. ROCK inhibitors are basically Rho kinase associated coiled coil containing protein kinases. These were actually the first downstream effectors that were discovered. And they essentially exist in two isoforms, ROCK1 and ROCK2. Now we have two, approved glaucoma medications that are ROCK inhibitors. And these are, these medications work by affecting the trabecular meshwork, relaxing the smooth muscle and increasing outflow through Schlemm's canal. But basically, starting even as early as 2009, Dr. Kinishida's group was looking at the effect of ROCK inhibitors on endothelial cells, and actually was able to show that these medications, in particular Reposidil, promoted corneal endothelial proliferation in cultured human cells, as well as affecting wound healing and endothelial regeneration in a rabbit model. And then in 2017, Dr. Greg Maloney from Australia also reported the use of ROCK inhibitors in 3 patients who had failed DWEC 2 to 4 months after surgery. And basically by treating those patients with Reposidil 6 times a day for 2 weeks, we're able to show reversal of the edema and clearing within 2 weeks of therapy. So ROCK inhibitors, I think we're going to continue to look at those drugs to enhance the outcomes of DWEC surgery, but I think this area is still an area that has not been fully investigated. Now, not everyone thinks that this is a good idea. Actually Dr. Price's group published something in 2014 basically saying that the prolonged corneal edema and associated symptoms resulted in less desirable postoperative course compared to rapid corneal clearing regularly achieved with DMAC. And, part of that's true. Also, Dr. Koenig in 2015 basically said because of the relatively poor postoperative visual acuity and slow visual recovery, simple descemetorrhexis is not an acceptable form of treatment for Fuchs endothelial dystrophy. And I think that there's been a shift in thinking about that, as we know that several people in this group here do perform this procedure. And, I think that basically this most recent paper from Pittsburgh from Dr. Dhaliwal really highlights the difference between DMAC and DWEC, excuse me. And what they showed is that basically, the number of people achieving 20/40 or better with DMAC versus DWEC was very similar, not statistically different. Of course, the time to achieve 20/40 vision was almost 2.5 times longer with DWEC compared to DMAC. But adverse events, this is what stands out. DWEC, 0. DMAC, 53%. So, we deal with a lot more problems with DMAC potentially compared to the DWEC procedure. And, additional procedures in the DMAC group here was 13% versus 0 with DWEC. So I think there are a lot of advantages to the DWEC procedure or DSO procedure. I do think we are trying to sort out the details about which candidates are the best. I think the mild to early moderate are really the best group to target for this with healthy peripheral endothelium. Age may play a role. I think probably younger patients have probably more regenerative capacity compared to older patients. Basically, you know, surgical technique is very, very important. I think this stripping, healing versus scoring is very important. Centration is important. I think the use of ROCK inhibitors is not necessary. And actually our first publication, we didn't have any of our patients on ROCK inhibitors. And, you know, we had more than 80% of patients clear. We are actually going to go back and review our 3 to 5 year data to see how patients do. I've had maybe over the years, I've had only 3 patients that have needed to be converted after not clearing with endothelial keratoplasty. And the other issue that I think has not been discussed is the role of intraocular pressure. I personally believe that the intraocular pressure in DWEC needs to be very low. So I target for patients to have IOPs of 15 or less, as I feel it helps in endothelial cell recovery. So thank you very much, and appreciate the opportunity to speak.
Thank you, Dr. Roboto. That was a much awaited talk. We've not had it on the Indian turf as yet, much on DWEC. Just a quick question as to when do you convert from DWEC to DMEC in these patients where you've been not successful with DWEC?
So Nidhi, I've waited up to a year in some patients before clearing, but in general, I tell patients when I talk to them preoperatively, if they're very, very unhappy with their results at 3 months, or if we're not seeing progressive improvement by 3 months, we could consider endothelial keratoplasty. Again, the 3 patients I treated, both had waited more than that. I think one was 6 months, one was closer to a year. Before I ended up doing DMEC surgery for them. I do strip a larger descemetorrhexis for when I need to do a DMEC surgery. So we only have a 4 to 5 millimeter initial strip. There is a little bit of lag in recovery centrally of the central edema, but it does clear up for the patient, but it's not like a standard DMEC surgery. I think it takes a little bit longer to recover in my experience, but I would, again, if anyone has experience here in this group, I would love to hear their experience with this.
With that, any questions from the faculty, masters? I think Dr. Sunita had a question which you already answered, was does the age matter? And you did answer that the younger patients would do better than the older one.
Yeah, I think patients over, at least in my group, they were all over 65. So, you know, I think when you're dealing with an older patient, that said, I haven't really broken down the age group because I have had patients over 70 who I've done this procedure on where it's worked just fine. But again, I think in the beginning, when you're trying to decide who might be a good candidate for this, it's better to probably choose a younger candidate to start with. But it's very impressive. I've had people clear as little as 2 weeks, which is phenomenal. So, but you know, if you think about this, you're really not using cornea tissue that could be used for another patient. There's potential financial benefits. And not having to require lifelong steroids, not having to worry about rejection. These are all very positive attributes to this procedure.
I think, Dr. Roboto, we have a lot of questions on the chat box with you. Would request you to answer them there since we have actually...
Sure, absolutely, no problem. I will do that, no problem.
Yes,
thank you.
Yes. We'll go on to Dr. Tiziano's talk. And I think we've had a very long discussion on the innards of endothelial keratoplasty. All the viewers, please wait for the quiz. I know it's been a tiring, long session, but we're going to end up with a quiz soon after Dr. Tiziano's talk. Go ahead with your talk, sir. your screen? You want to start?
Okay.
Yeah, Dr. Tiziano will be talking about. Yeah.
Okay. Good afternoon, everybody. It's a great pleasure to me to be here in this great group. Thank you very much, Nidhi, for inviting me. Today, I am going to talk about medical therapy for endothelium disorders. I will start about talking about ROCK inhibitors. As you know, ROCK functions as an effector molecular of the ROA signaling with important roles in regulation cell morphology, motility, and polarity via its rearranging effects on the actomyosin cytoskeleton. Specifically, activation of ROCK leads to formation of actin stress fibers, increased cell-cell junctions, as well as increased cell extracellular matrix interactions. The raw ROCK pathway has therefore an influence on various important cellular functions, such as maintaining cell shape, motility, adhesion, proliferation, and apoptosis of the cells. As you can see here, ROCK has been researched as a potential therapeutic target for vascular disease, cancer, neuronal degenerative disease, asthma, and glaucoma. Only 3 drugs have been approved for clinical use: fasudil, ripasudil, and netazudil. The fasudil is approved for the treatment of cerebral vasospasm in Japan and China since 1995. Ripasudil, it is approved for the use in glaucoma or reducing intraocular pressure in Japan since 2014. And the last one approved was netazudil in the United States in 2017. As you know, ripasudil administered twice daily has been proven to lower intraocular pressure by altering cytoskeletal contraction of the trabecular meshwork and Schlemm's canal cells, increasing this way the outflow facility of aqueous humor. Ripasudil is a highly selective for both ROCK1 and ROCK2 with minimal off-target effects as a result. Its safety was demonstrated in phase 3 clinical trials for ocular hypertension, and the main adverse event recorded was conjunctival hyperemia in 70% of the cases. As you can see here in this slide, mostly due to protrusion formation along intracellular borders caused by the reduction in actomyosin contractility of the cornea endothelium cells, as you can see in this picture. It is very important for the physicians that are starting to use these kind of drugs that should appreciate that ROCK inhibitors can cause these Guttae-like findings in order to avoid misdiagnosing patients as having Fuchs endothelial corneal dystrophy. The ROCK inhibition as a potential promoter of cornea endothelium healing has been promoted and pioneered in recent years by Professor Kinoshita. Here in South America, it is currently out of label. We cannot use these kind of drugs. As you know, the cornea endothelium is a monolayer of cells which is formed from neural crest-derived cells. During development, human cornea endothelium cells proliferate and migrate centrally to form a continuous mosaic of cells facing the aqueous humor. Cell-cell contact induces growth arrest in J1 phase through contact inhibition mechanism, leading to the formation of a monolayer this study this is a recent study, demonstrate that few proliferation cells were found exclusively in the extreme periphery of the endothelium of human cornea with a short post-mortem time. And that a very slow and continuous centripetal cell migration might exist to partially compensate the physiological cell loss in vivo. This intervention of these cells, the intervention of these cells could regenerate a person's own endothelium cells, even in cases of Fuchs, as an alternative to transplantation cornea from a donor. Yeah. This concept is very important in our practice. The doctors who are doing endothelium keratoplasty, we all know that when we have the endothelium cell density, when we have good endothelium cell density in the periphery, we are going to do small grafts. And when the periphery is not so good, we are going to choose big grafts. Professor Kinoshita, in this study, he demonstrated that the ROCK inhibitor improves culture efficacy in primary monkeys' cornea endothelium cells, increased frequency of proliferation in monkey cornea endothelium cells, and promotes wound healing in rabbits and in monkeys. Cellular stresses to the corneal endothelium activate ROCK MLS phosphorylation, which induce the loss of cell adhesion and promotes apoptosis of the cells. The ROCK inhibition was proved to suppress these chains of events and prevent apoptosis in these kind of cells. In this study, the study is very important because they demonstrate for the first time that the ROCK inhibitor is not toxic, does not induce proliferation, and does not modulate apoptosis. Treatment with ROCK inhibitor could not overcome anti-proliferative mechanisms induced by contact inhibition ex vivo. However, it promotes cornea endothelium wound healing by engaging endothelium remodeling, adhesion, and cell migration. As you can see in this slide, we all know that ROCK inhibitors promotes ex vivo wound healing, induce a totally wound closure after 12 or between 12 and 24 days, while acellular areas could be still observed in the control group, as shown in this in the left picture. Okay, here. So Roberto Pineda talks about the DWEB DCO. This study is very interesting of Gregory Moloney. He chose 12 eyes with central gutae and healthy periphery to combine these treatments. He have done a central descemetrorhexis under viscoelastic, as shown Roberto. They not exceed 4 millimeters diameter, and they use ROCK inhibitors 6 times a day. The results were very good. They have 9 of 12 eyes spontaneous cornea clearance in the first 6 months. Okay, here you can see that they do not need to use the ROCK inhibitor for more than 2 weeks, and confocal demonstrate stable hexagonality cells. As you can see here in this study, the observation of the possible mitotic bodies on confocal scanning may indicate that some cells division is stimulated by the removal of cell-cell contact inhibition. The downward trends in cell counts, however, would suggest that it is still cell migration that is chiefly responsible for healing in these cases. Another of ROCK ROCK inhibitors and DCO, you can see in the pictures of the specular micrographs that in the case when they're used combined with ripasudil is better than in the micrographs that they don't use the ripasudil. Here you can see this study that it was done in the Veneto Eye Bank in the north of Italy. The purpose of this study was to investigate if the peripheral cornea endothelium that was discarded after the preparation of preloaded DMEK could be successfully used for cornea endothelium cell culture. These are the outcomes in these pictures. You can see in the left one, you can see the immunostaining and expression is very similar in the complete endothelium compared with the peripheral endothelium. In the other picture, you can see that the morphological analysis is very similar in the complete endothelium and in the peripheral endothelium. Here you can see in chart A, the confluence rates comparing the peripheral and the complete endothelium are very similar. In the chart B, you can see the difference in cells areas. In chart C, the hexagonality and the polymorphism is in both groups are very similar. And in chart D, you can see that the Ki67 positivity compared between both groups is better in the peripheral endothelium. So to finish the conclusions, you know that the pharmacological approach to the cornea endothelium cells recovery is very attractive. The inhibition of the raw ROCK signaling by the specific ROCK inhibitor was proven to promote cornea endothelium cells proliferation and wound healing. This kind of therapy is not toxic to the human eyes. GWEC cases may be candidates, and long-term effects is still remaining a question. Cell regeneration is going to be the future. Personally, I think that cell regeneration and the ROCK inhibitors are going to be the future of the cornea endothelium disorders combined with our actually endothelium keratoplasty. I think that in the next few years, we are going to combine these new therapies with the old therapies that we have today. Thank you very much.
Thank you, Dr. Tiziano. I think the last two talks were very enriching for the upcoming future for these disorders being treated without any surgical intervention. As rightly pointed by Dr. Roberto also, I think for now the take-home messages, they have specific indications, specific patients in which we would be doing, and we would be looking for more improvement in this technique and better results to serve our patients. With that, we come to the end of the academic session. Although the quiz is awaited and we'll be taking up Aditya on it. On behalf of the Shroff family, the technical team, the core group of Eklg, our mentor, Dr. Praveen, behind us, and all the absolutely fantastic faculty who has been with us all throughout the practice sessions, taking us our needs for their talks and giving us their precious time for such a long session that we had on the innards of endothelial keratoplasty. I would like to thank all our participants also for being with us from all over. Please await for the quiz. I would invite Aditya to take over and announce the requirements for the quiz. And we would announce the winner next week, I think probably by Sunday. Over to you, Aditya. And thank you, everyone. The session has been great. I think it's prolonged above the usual time it gets over. And that's because it's been really contributed by everybody from the faculty as well as from the participant side. We will be taking up your questions on the WhatsApp from here, and they'll be posted for the masters on their group to get back to you with the answers. Over to you, Aditya.
Yeah, thank you, Dr. Nidhi, and I thank each and every one of you for staying till the very end. So the quiz is very simple. We have 10 questions, each having one right answer. There are multiple choice questions. So I'll be posting the links very shortly on both the WhatsApp groups in which some of you are members either of one group or the other. So the timer starts from then. You have 10 minutes. I'll give 1 minute extra for inputting your name as the first question. So once the time is up, the survey will be closed. You don't need any special software to open this. You just click on the link and the survey starts. So all the best, happy quizzing.
With that, I think we come to the end of this webinar. We'll see you again in the future webinars, and we'll be announcing it on the group. Thank you, Dr. Roberto, Dr. Tiziano, Dr. Rahul, Dr. Sunita, everyone, all the faculty on board with us, Dr. Dipender, and keep safe during these COVID times. See you back. Thanks.